we welcome you on behalf of IIPTNSC, Dr. Shaila. With this 5 word, let us go for the deliberations. We are very happy about it. Oh, back to Rajendra.
Thank you, Ismail sir. He is our dynamic president, and we are doing a lot of activities past 6 months. Thank you, sir. And now I welcome Dr. Agila Ayavu, endocrinologist, leading pediatric endocrinologist in Coimbatore, and today's program is a convener, and she is going to tell a few words followed by your inauguration.
Good evening, ladies and gentlemen. It's a deep honor and a pleasure to be here today. Thank you so much for the kindness and being prompt in attending on a Sunday evening, particularly at 4 p.m. as Ismail said. I'm deeply thankful to Ismail, all my friends, Ismail, Rajendran, Dr. Gopal Subramaniam, Dr. Sendil, Dr. Ramesh Babu, and our session experts, Professor Lakshmi Velmurugan and Dr. M. Ramasamy sir, and our speakers who have been very, very kind in accepting our invitation. I'm deeply thankful to Dr. Shaila Bhattacharya, who is the current president of the Indian Society for Pediatric and Adolescent Endocrinology from Bangalore. I'm thankful to Professor Raghupati, who is almost a native of Coimbatore, missed it by an inch, I think, by settling down in Bangalore rather than Coimbatore, who's also a deep friend to all of us in Coimbatore. Then I would also like to thank Dr. Vaman Katilkar for his kind acceptance. We actually had changed the date. He was still kind enough to accept, and I think he needs no introduction. He's a towering personality in pediatric endocrinology. And then I'm also thankful to Anna Simon, who's my close friend, and she's the professor of pediatrics and pediatric endocrinology from CMC Vellore. I'm really thankful to our stalwarts, Professor M. Ramasamy sir, and I'm seeing Dr. Srinivasan sir from JIPMAR, who's very, very prompt in all his sessions, and I'm really thankful to all the seniors and the attendees. Thank you so much, IIPTNSC, for this opportunity, and I hope you all enjoy this session. I would like to welcome Professor Lakshmi Velmurugan, Professor of Pediatrics, and has special interest in pediatric endocrinology from the Institute of Child Health and Hospital for Children, Madras Medical College, Chennai, to be the session expert for the first session. And I welcome you, and please take over the proceedings, madam. All the best.
Thank you very much, Agila Ayavu, madam. I think she's a convener of the whole program, and madam has handpicked the topics. That is, these topics will be of use not only to the pediatric endocrinologists, it's of great use to the pediatricians, and all of our postgraduates have probably entered into the session, have joined the session, madam. Thank you so much for the opportunity. At this point of time, I would really like to thank IIPTNSC under the presidentship of Dr. Ismail Muhammad and Secretary Dr. Rajendran sir and Gopal Subramaniam sir and Tirumurugan sir. They are doing a great job. They are empowering all pediatricians, PGs by the PG sessions, practicing pediatricians by pearls for practicing pediatrician sessions, and subspecialty and subspecialty CMEs. What not they are doing, I don't understand. They are taking us by a whirlwind, and all of us are really very happy. Also, I feel that from Chennai, the whole thing has shifted to Coimbatore and the peripheries now, sir. We are under your, excellent leadership. It's a very great and a very, it's a very nice thing to be part of this young and dynamic team. I'm really very happy. Now, I would like to, move on to this session. The first session, now we are having 3 sessions. The first session is going to be approach to an obese child. Need of the hour session, because initially we were banning cell phones from the schools. But now the whole school is inside the cell phone. The teachers, the class, the students, everybody, they are on the screen time. Instead of being 1 or 2 hours of academic time, now it is going to be 6 to 8 hours screen time. It has become mandatory for the children because of these school hours. And after facing an epidemic of COVID and MIS-C, as soon as the schools open, I don't think we are going to open the schools in the recent future because the vaccines are not seen for the young age group. We are going to face an epidemic of children with obesity. Definitely, we are going to face this. And the ideal person who's going to talk about that is going to be Dr. Shaila Bhattacharya, ma'am. I'm very happy to see that the president is Indian Society of Pediatric and Adolescent Endocrinology 2021 to 2021 is going to deliver this session. Madam is a professor at Department of Pediatrics, JJM Medical College, Davangere, and a pediatric and adolescent endocrinologist of Shivajyoti Clinic and Manipal Hospitals, Bangalore. She is the convener of many pediatric endocrinology fellowships. She has authored many endocrine and pediatric textbooks, and she has published more than 30 original articles. Over to you, madam.
Thank you, Dr. Lakshmi, for your kind words. I thank Team Tamil Nadu IAP for inviting my dear colleagues and friends and me to this academic feast. I'll start sharing my slide. Can you see my slides?
No, ma'am. We are able to hear you. Slides yet to be seen.
I don't know what happened.
Share screen.
Yeah.
That part. Yeah.
Yes.
Yes, madam. Yeah, your screen is keen, madam. Please.
Yeah. As Dr. Lakshmi said,
yes.
We have now not one pandemic. In next 1 year, we will have dual pandemic because the obesity is going to really boom along with the COVID infections, especially the MIS-C in children in next 6 months to 1 year. So you can see this new pediatrician-friendly BMI charts. I'm sure you all are aware of this. I'll come to that, but what is happening in next few years, I don't know. That would be my answer. I am going to start with the horror stories. Horror because every child who walks into your office practice is not a simple child who comes for vaccine. You can see this child came to me for vaccine and then mother showed some black marks in the neck, which were acanthosis nigricans. When we took the history, there was a family history of type 2 diabetes. There was dyslipidemia. Grandfather had already done angio and he also died with stroke. And when you see this little boy, he looks nice, handsome chap. But if you just undress him, you'll know the story, how he looks behind the shirt, even though he's the best son for the parents. And then we plotted him on the chart and you can see where his height and weight are. You can see this height is on the 97th centile. Weight is gone above the 97th centile. And you can see in the BMI chart, he is here. And we had to convince him to do the metabolic workup because there was a strong family history of metabolic disease in. So we found that he had cholesterol of 230, LDL 151, and his vitamin D was low. And so we could only just tell him diet, exercise, and lifestyle management. Next were these two adolescent sisters. Similar picture, you can see that again, obese, they come for something else, but they turn out to be some other surprise. Again, these, you can see the height, weight, and BMI. And again, you can see that the workup showed that both the sisters, you can see the glucose after 2 hours of OGTT, 282, insulin was more than 300, cholesterol was high, triglyceride was in 400, LDL was 118, low HDL. Similarly, the other sister, you can see her growth chart and even her values were not surprising because even in their family, the same problem of diabetes and hypertension and stroke. So all these three children, you can see that, especially the two other older children, they had type 2 diabetes, otherwise exogenous obesity, type 2 diabetes, dyslipidemia, and metabolic syndrome. So I think we can only advise diet modification, exercise, but in these two girls, we can put after the failure of these first two, the medical therapy or the medications. So how big a problem is pediatric obesity? If you see there, 2 to 5 year old, there is a prevalence of 22.6% of overweight and 31% in 6 to 19 years, whereas obesity is 10.3 in 2 to 5 and 16% in 16 to 19 years. This was the survey done in 2009 to 2012. Sorry, it is still 12. And if you see the prevalence in India, this is before 2011, there was a similar prevalence. You can see that it varied anywhere from overweight was from 5.7 to 11.7, and the obesity was nearly from 15 to 30%. And what has happened? The prevalence of overweight and obesity in 2016 in the age group of 5 to 19 years, if you see here, in all the different places, including in India, it is like 48%. And the estimation is by 2030, 254 million children will be obese worldwide, where you can think of 100 million going to be added in the next decade. And what we are seeing now is only tip of the iceberg. We don't know how much is behind this. The latest, whatever I could get, is till 2017 in our own cities like Bangalore, Coimbatore, Mumbai, Chennai, and Pune, the incidence of overweight in Bangalore, Mumbai, and Pune were matching, both for overweight and obesity, whereas Coimbatore and Chennai had a little bit better incidence prevalence in obesity, where it was 6 and 7% compared to 17 to 10% in Bangalore, Mumbai, and Pune. So I think you people are doing better than our cities. So we need to follow yours. So what do you mean by overweight and obesity? Overweight is if you are using the WHO charts and if the BMI is more than 2 standard deviation, and obesity is more than 3 standard deviation. If you are taking for children above 5 years and you are using IAP charts, the BMI, I'll be showing the charts in next few slides. The adult equivalent of 23 and the BMI above 27 would be defined as obesity. So how do you measure obesity? Is it as simple as we keep calling obesity? So there is a conflict of measurements. Is it waist measurement better than BMI or BMI better than waist measurement? So to define BMI, it is body mass index, which is calculated by weight in kilogram by height in meter square. Whereas the waist measurement, which is actually, I feel it's not very standardized, and especially in children, because the measurement points need to be really accurate. The waist at the level of umbilicus, or is it in between the umbilicus and the spine, supra iliac spine, or and then the maximum width of the hip. So we need to have more standard measurements for these. So I would right now go on with BMI. But there are also disadvantages of BMI. If you are very tall and overweight, it may not show very much. But the importance of waist measurement is if the waist or the measurement, or if there is central obesity, then it is more likely that you are at the higher risk for developing metabolic syndrome. These are the BMI charts for girls, WHO BMI charts, and these are the BMI charts for boys, which we all know, which are color-coded boys and girls. When should we worry? When you are plotting these children on the growth chart, and if the overweight, that is BMI more than 85% with a family history of metabolic syndrome, you should be very concerned. Or if the BMI is more than 95th percentile, or you are following up the child with a good growth chart and you are seeing that the weight centiles are jumping. If it has been on the 25th or 50th and suddenly going on to 75th centile, I think you should start warning the parents or the caretakers. So I'm going to show one more chart here. A 15-year-old girl who has come to you with a height of 160 and weight of 62. If you mark them on the chart, you can see that by height she is on the 75th centile and by weight 90th centile. If the same girl is plotted here, she is on the 23 adult equivalent, which is above there, so she is overweight. So the diagnosis in this girl would be overweight. This 10-year-old boy, you can see that his height is on the in between 75 and 90th centile, and his weight is above 97th centile. And if you plot him on the BMI chart, you can see that he is here well above the 27th equivalent of adult equivalent. So he is in the obesity range. So he is obese, and we call this as exogenous obesity because he is tall and obese. In the next chart, I want to show you, here is a 9-year-old girl who has come with a weight on the 75th centile and height below 3rd centile, but she is also obese. So that is what I was telling. Sometimes you may get who is short also, but you can see here she is short and obese and her BMI is high. So you should think of something more than a simple obesity or exogenous obesity, what we call as pathological obesity. There are also other methods where you can do the fat estimation, especially which can tell you about the metabolic complications. I will not go into detail about this because these are mostly used for research purpose. What are the common causes of pediatric obesity? If you take obesity, it's either exogenous or endogenous, which we already showed in our growth charts. So even if you are in a peripheral center, you can diagnose at least the etiology of obesity by marking them on the growth charts. Coming to the endogenous obesity, what are the most common etiologies? Endocrine, which would be Cushing, hypothyroid, growth hormone deficiency, genetic or any other syndromic, and also hypothalamic, and then if they are on drugs, especially steroids or antipsychotic. So you need to know that here children are short and obese. A good history and examination is very, very, very important if you want to make a simple clinical examination, simple clinical diagnosis. So if the history and examination is normal and you have plotted them on the chart where the height and weight are both above, then you would think of exogenous. But if you think that it is abnormal, then you should start searching for the etiology, which could vary anywhere from the infancy till the adolescent. So if you have an obese child at an early onset during infancy, you should think of monogenic obesity. If the child is short and obese, think of endocrine obesity. If the child has hyperphagia, developmental abnormalities, dysmorphism, hearing or vision, then you have to get the help of the genetics and do genetic studies. And if there is any CNS injury, you would think of hypothalamic obesity. A good history will tell you how to go forward. So age of onset, like what I said, age is very important. Whether the child was born small for date or IUGR, or was big baby, or the child was born to a GDM mother, and how long the obesity, is it an acute onset or has been chronic? The birth details, like what I said, is the baby IUGR, which is very important, and how was the feeding habit is important. Any injury, meningitis, encephalitis is important. Developmental history of hyperphagia. It's not only eating more, but craving and cheating and stealing food, that also has to be taken, because some of the syndromic obesities can have these things. And short stature and scholastic performance, if poor, you can think of endocrine obesity, which could be hypothyroidism. Check for the visual impairment and deafness, again, some of the genetic conditions. See for the puberty, whether it all has started peripubertal age group. Medication is very important because you may miss and the child may be having steroids for some reason and child would land up with obesity. And lastly, the family history to rule out the metabolic syndrome. Never forget to take a good diet history because that will really help you how to go about in the management. Next is the screen time. As already Dr. Lakshmi has told, 2 years back, we used to tell reduce it to half an hour, but now the children are in the mobile, not the mobile in the school. So now minimum duration is 6 hours. So when we have to ask, we need to ask when is the online class screen time and offline class screen time. That will help in counseling the child. Physical activity is very important. How many hours, how many minutes, how many seconds child is doing, because then you can counsel better. And also check for complications like anything to do with headache or limping or any other associated complications secondary to obesity. Once you have had a good history, go for an examination where I have already told you about the BMI measurement and plotting on the growth chart, doing the skin fold thickness and waist hip ratio, check for the height and mark on the growth chart. Then body fat distribution, again I have mentioned where central obesity is bad, so this can be detected by doing the waist circumference. See if there is any dysmorphism and do a pubertal staging. See for acanthosis nigricans and also skin tags, because these are the markers for metabolic abnormality. So these things are the minimum things which you need to do in the examination. Going back to another case, you can see this lovely looking 1-year-old child again had come for vaccine, and when the child has been plotted on 70, child's height was 75 and weight was 15 kilos, and you can see the child is gone above the 3rd centile in the WHO chart. And again, as I said, good history is the key thing. And when we took the history and mother said she just doesn't eat anything, then how is she surviving? She's taking only 1 liter of milk. So the culprit is that 1 liter of milk and not the problem of the mother that the baby is not eating, and she's adding all the additives which have been prescribed by the doctor because mother always tells she's not eating. So this child was taking Pediasure, Horlicks, Milo, whatnot, even at 1 year of age. And she just required good counseling. And within 6 months, she lost and she came down to 12 kgs. You can see the BMI coming down and even the weight coming. So, so history is very important. And especially if you take a good history, you don't need to refer these children for obesity to any specialist, and these can be treated at your office itself. Similarly, if you can see this child really looks very obese. So if you have taken a good history and done a good examination and ruled out, then you should think very early onset infantile obesity. You need to do genetic test and rule out the monogenic obesities. Coming to some of the another case. She's a girl, 8-year-old girl who came from Uganda. Actually, I saw her 2 months back, and you can see her face. This mother had seen at least, I can't tell the numbers, but she had seen the cardiologist, she had seen the nephrologist, because the only complaint mother had, the girl has a face. Nobody bothered to do anything for her. And when we plotted her, she was short and overweight. You can see her height, weight, and BMI chart. And if you can see, I'm sure you all will diagnose, because you all are well trained in endocrinology after so many classes, I'm sure you will diagnose this girl as soon as she is walking into your office as a hypothyroidism. And she was hypothyroid. Her TSH was 1100 and free T4 was 0.4. Her antibodies were positive, and within 1 month she showed so much of improvement and she's doing very well. So such simple things I think we should not miss. And you can see that just the growth chart and looking at her, you could decide what investigations to do and not to go for any fancy investigations. Simple thyroid function tests with the antibodies gave you the diagnosis and she would improve very well. This child, if you see, this child was given bectazole drops because child had got some infections and mother forgot to go back to the pediatrician, and after 2 years she came with obesity, and I'm sure you would have made the diagnosis of exogenous obesity, endogenous obesity, exogenous Cushing syndrome, because of the bectazole drops. So whenever you prescribe any medication, make sure you call them back and review them for their height, weight, and take a good history, and also the medication history, whether they have stopped the medications. Coming to this boy who came at 10 years to us, not only for obesity, but also short stature, and had severe headache for more than a year. And he turned out to be craniopharyngioma, and turned out to be growth hormone deficient. So he was short, obese, and all the signs and symptoms of GHD were there. And he was treated for craniopharyngioma and growth hormone deficiency. And if you see this girl, again short, obese, and she had developmental delay, and again this was one of the genetic syndrome. She turned out to be Prader-Willi syndrome. You can see this beautiful two 11-year-old girls, both came for short stature and obesity, and on a good examination both of them had short metacarpal and metatarsal with distinct facies with micrognathia. You can see here short metacarpals here by X-ray also, and here this is very obvious. And when you examine, you need to really examine them thoroughly, because you miss the diagnosis. Even though they look similar or behave similar, they both were two different cases, one where the genetics proved to be Turner syndrome, then the biochemistry proved to be Albright syndrome. So not only clinical history examination, the supporting biochemistry or the genetic test should help you in making a proper diagnosis. Some of the rarer things, the genetic or syndromic dysmorphic are, you can see this little girl who turned out to be Prader-Willi syndrome. When the history was taken, she was born small. She was very difficult to feed. She was hypotonic. She failed to thrive. And after 1 year of age, she started putting on a lot of weight, and she was hypotonic, and she turned out to be Prader-Willi syndrome. You can make a diagnosis with a FISH test, and sometimes if your clinical judgment is more sure, even if FISH is negative, you should go ahead and do methylation test where it may turn out to be positive. Similarly, there are a lot of genetic obesities. You can see Lawrence LMBB, where you can see polydactyly, syndactyly, hypogonadism, visual problems. Similarly, Cohen syndrome, where you have prominent incisors, and then you can see Alstrom syndrome, then again Rohart syndrome. So many are there. Many times, if these dysmorphic features are there, you have to get the help of the genetist to see and make a diagnosis. So after all this history examination, what investigation should be done and why we should do these investigations? If you see here, both the morbidity with the obesity and the mortality with the obesity is increased. With the obesity increasing, with the increasing BMI, all the metabolic syndrome like hypertension, arthritis, dyslipidemia, diabetes, everything increases, thereby mortality also. So whom to assess and whom to investigate? That is a big question, but I would always suggest any child who is overweight with a metabolic syndrome or problems in the family, and any obese child who is above age of 2 years, I think you should do a complete assessment and do at least minimum investigations. So what investigations? I think simplest would be doing just overnight fasting and doing the test fasting sample. You do a sugar, insulin, hemoglobin A1C, and cholesterol levels. If required and you are suspecting and the BMI is very, very high, then you can go for OGTT to see if there is, you want to detect the type 2 diabetes. With these values, you can also calculate HOMA-IR, and if it is more than 4.5, it is considered as abnormal. What can we do to stop this epidemic? It's nature versus nurture. So we have bad genes, or the child with obesity has got bad genes, and you are compounded with environment. So landed with obesity. We cannot change our genes. We can only change our environment. So the only way we can do this is completely change our contributing factors with a screen timing, diet, parental education. So if you see here, children who are having super sizes which have increased, a child who is obese as a young can develop as an adult obese man. And also you can see you are getting the best in India, in I think most of these cities, you are getting the best of the South Indian, where he is enjoying, not South Indian, both of the Eastern and Western food. So they are really happy with all these junks, and they are increasing their weight and landing with obesity. So how can you manage this? So integrated weight management, these are the 5 pillars what I would suggest. Diet, physical activity, lifestyle modification, psychological support, and pharmacotherapy. And tender loving care. I don't think it is only tender loving care. It should be a total lifestyle change, which means TLC. So I'm going to start not with the diet, but with the pharmacotherapy, because everybody is interested in pharmacotherapy, not these 4 pillars. So pharmacotherapy, 2017 Endocrine Society guidelines have suggested pharmacotherapy for especially adolescents if they have failed in the lifestyle modification. And FDA has approved medications to be used and should be discontinued. More than 4% BMI or Z score reduction is not achieved after 12 weeks. And the recommended medications are metformin about 10 years, orlistat about 12 years. And these are the rest of the medications which have been tried, and the bariatric surgery. But to tell you frankly, in my last 20 years of practice in India, I have not used metformin or orlistat for even for one child who is a simple obesity. They are all only for the metabolic syndrome where they have been used. For simple obesity, I think you have to follow the first 4 pillars which I mentioned, and the famous junks. I think after our president, you all are sure about the junks, which stands for junk food, processed food, nutritionally inappropriate food, caffeinated, colored, carbonated foods and beverages, and sweetened items. So basically, you need to stop all these high glycemic food, go for low calorie, low fat, and take lot of vegetables, grains, and fruits. The best nutrition guide would be going for the healthier eating, where fat is reduced, especially saturated fat. Go on less on sugar, go less on sodium, and be in the green zone. The simple thing I tell the child to write the names of the food which are starting from C, and he will write all these things like chips, candy, chocolate, cake, coke, cheese, creams, chicken, and the list doesn't end here. So, and at the end, I would say you have to stop all the food which you start from C, which is really not giving him a happy smile there. So how can we prevent? So I think the prevention starts at multiple levels. The first would be the family level, where healthy dietary habits and physical activity should be encouraged. It should be a family time, family together. All activities should be done together with the family, and enlist whole family for obesity prevention, and decrease screen time to half or maximum 1 hour per day, which is non-school screen time. It is always better to do with the child rather than telling you do it and I will see it. Next is the school level, promote physical activities for students, promotion of activities stressing the importance of healthy lifestyle and diet, and encourage behavior changing interventions. Community level is what we need to aim right now, because we need to do a lot of obesity awareness programs, not for the doctors, but to the public. And also we need to identify the at-risk adolescent at very early age and take appropriate preventive measures to prevent comorbidities. So where is the role of we pediatricians? I think we every day when we watch television, we see all these ads. You can see all the famous actor, actresses, and the sports person are showing, and these commercial ads. So the kid is really carried away with these ads and tries to follow them, thereby increasing the screen time, increasing the bad habits of eating. So I think we need to really attack these things at really a community level, and it can happen only when we all doctors get together and advise the government. I'm sure you know who this person is. People who are fans of football, you know Cristiano Ronaldo. Last week, he refused to take Coke and he took water bottle after he won the 107th goal. And immediately the Coke's market plunged by 4 billion in US. And now he is endorsing for water. So I think we need somebody, our own people, the famous people, so-called famous people, whether in the film industry or in the sports, to endorse these things and get our children and people to follow it. Everything is not a horror story like how I showed my first 3 kids. So here is my another girl who was again obese. You can see her, and she had obesity, dyslipidemia, abnormal OTPT, vitamin D deficiency. She was just advised diet, exercise, reduce screen time, lifestyle modification. She lost 7 kgs after 1 year, and she looked normal. And you can see her, all her metabolic parameters, cholesterol came down to 120, triglyceride reduced, HDL improved, OTPT also reduced. So I think this is where our role stays. Repeated counseling, every visit, you need to counsel them, get a full detailed diet history, exercise pattern, and then advise them accordingly. This is my last case. She's only 4-year-old. She again came for some trivial infection, and that time when we saw her and plotted her on the chart, you can see, and the parents refused to admit that she was obese. But after again good diet and exercise counseling, even at 4 years, this is how she was. Within 3 months, you can see the change. So I think there is the advice what we need to give. Rather than prescribing any medications, I would advise you all to go again and again on history, diet, physical examination. And these are the most important beliefs by many parents, grandparents, caretakers. Fat child is healthy, obesity is a baby fat and it will go away. So they always love to force feed or overfeed and use food as a reward. And I've seen even a 10-year-old is fed by the mother before going to school. I think these should be completely stopped and advised not to do. And I put here good referrals because many times as endocrinologists, we get referrals for small phallic length or gynecomastia, but this is a very penis because of increased suprapubic fat, and this is lipomastia because of the exogenous obesity. So we can really tackle them as endocrinologists, which could have been easily done by the pediatrician. But that is why I've said this is a good referral, because we will retrospectively take good history, advise them, and then they are really happy with this. So growth charts are windows for diagnosis in obese child and adolescent. So if you have obesity with tall stature, it's nutritional obesity. If you have obesity with short stature, poor growth velocity, and delayed bone age, it would be non-nutritional or pathological. So the take-home message, I would say, children and adolescents are not miniature adults. So you need to handle them differently. Screening high-risk adolescents, prevention should be the goal for all these things. Thank you very much for your patient hearing.
Thank you very much for that wonderful presentation, madam. Switch over to from tender loving care to total lifestyle change. That was your mantra as a president of ISPE. It was a very nice caption. And again, reiterating that growth charts, instead of using percentile charts of 85th and 95th centile for overweight and obesity, we should definitely use the 23 and 27 adult equivalent BMI charts. They are more advantageous and they are very, and they pick up obesity early. That was your trick. I have one question, two or three questions for you, ma'am, and one or two questions from the chat box. The new obesity guidelines suggest that serum insulin should not be done. In your, are we doing it, madam? We are doing it.
You are doing it. I am doing it. I am doing it.
Okay, but then probably it should be in the guideline.
Yeah. Because I'm sure
insulin resistance, we have to
10 out of 100 will say you shouldn't do in this same group. And even as pediatric endocrinologist, we would tell that. But the thing is, if I do an insulin either pre-fasting or post, and I show the parents, see, you are in the borderline diabetes, that will really go and hit their head.
Yes, ma'am.
And it will really make their change. Next time, before we tell, they will do the insulin and come. Because they're so much worried.
Yeah, the president has endorsed it. Good. Next, madam, one more thing is this YY paradox. That is, the BMI may be normal for two individuals, but the fat content may be different. So do you suggest estimation of this fat content? Because you showed the slide, but as a passing mention, you said it may be research tools. Maybe it may be useful for estimation of the fat content.
Yes, it is definitely. So if you cannot do the research tool, even by doing a waist hip ratio, you can get it.
Yeah, yes.
That is also a very easy method in office practice. But if you want to do, you can do a CT or you can do a fat estimation. You can get now some of the commercial weighing scales are there where you stand and hold, you can get the fat percentile. I don't know how much good they are for children, but I am sure for adolescents, they can be used, and you know the fat content in these children. So you can think about the central obesity in them.
Among your obesity patients, how common is type 2? How commonly you see type 2 diabetes mellitus, madam?
It is not uncommon, I would say.
Percentage probably?
Percentage, I would say about at least 3%.
5%. Okay, we thought it was 5% around us in Tamil Nadu. We have estimated around 5%. Okay, madam.
But how is it you have estimated the obesity more? I mean, diabetes more than the obesity?
5%. 5% type 2 diabetes as 5%, madam. Among our diabetes children, children
diabetes
5%. Among our diabetes children, 5% of them. Okay, you are mentioning it as 3%. Okay, madam. Then metformin and orlistat, conventional drugs, as you said, they are no longer used in, we don't use it in simple obesity, definitely in pathological obesity. And liraglutide, any experience, madam?
I have not used to any kid till now.
Okay. Dr. Arunachalam from Nagarkovil has asked one question, madam. He wants to know about liposuction and bariatric surgery in obesity.
See, I can tell you one small quick story I might have told in some previous talks. I had a 10-year-old boy who was really a BMI of 30, and father was looking normal. But I told him, you have to do this, that, this. Then he looked at me. And you know what he said? It's all right, doctor. I have had bariatric surgery, so he also will have it. It's all right. Let him be like this way. But I think that is not the thing, because this will all definitely lead him into metabolic problems. And in children, that I don't think, unless there is a metabolic problem, I don't think I would send these children for bariatric surgery. And unless they are motivated, family is motivated, because even after surgery, you can gain weight if you are not really committed to follow the diet and exercise. So if you are doing that even without bariatric, why not?
Yeah. Last question, madam. NAFLD, non-alcoholic fatty liver disease, LFT cutoffs do we have, madam? Apart from our ultrasound findings? Like SGPT more than 25, 22, do we have?
It's only age-related OTPT we follow. We are not doing the ultrasound fat and all. Again, it is costly, and again going on doing, and then you'll have to repeat it after that. So the simple one would be just doing OTPT. That would help you in.
That's what I'm asking. Cutoff values around 30. Around 30, can we have it, madam?
Yes, 25 to 30 is.
So 30, you can have it. Okay. Thank you very much, madam. Thanks a lot for the wonderful answers. We had a really enriching session. Thank you very much.
Thank you.
Can you please stop sharing, madam? Thank you.
I have stopped already.
Okay. Now we'll move on to the next topic. Yeah, the next, growth without growth hormone. Growth without growth hormone. The topic by itself sounds very interesting. It is easier to treat growth with growth hormone because the diagnostic test, we have standard diagnostic tests, and again the treatment protocols are very clear now. But growth without growth hormone is it is interesting, but I have a feel it is very difficult to treat, because most of the time, most of these the presenting manifestations are not very clearly manifest, and they can be silent. And a common denominator in all these conditions is poor nutrition, growth hormone unresponsiveness, and inflammation. I would now request Professor Raghupati to come and chair the session and start with the proceedings. Dr. Raghupati is a professor of pediatric and adolescent endocrinology. He at Indira Gandhi Institute of Child Health, Bangalore. Sir is a senior consultant in pediatric endocrinology of Sagar Hospital, Tilak Nagar, Bangalore. His present affiliation is the chairman of Changing Diabetes in Children. This covers around 22 centers serving 4,000 children with type 1 diabetes mellitus. And Sir has been awarded the ESP, Endocrine Society and Pediatric Endocrinology International Outstanding Clinician Award in 2018 and APPS Honorary Lifetime Award for 2012. Over to Professor Raghupati.
Good evening, everybody. It gives me great pleasure to be back in Tamil Nadu, at least virtually. And I've had such fond memories about my time, my life in Tamil Nadu.
Sir, excuse me, can you be a little louder, sir? A little louder. Thank you, sir. Thank you.
I'm extremely grateful that I'm getting another opportunity to be in Tamil Nadu virtually, where I spent all my life in Vellore, and after my retirement for a number of years in Coimbatore as a visiting consultant. And thank you for inviting me. And without any further ado, I think I'll start off my topic. And I completed my endocrine training in 1986. 10 years later, I saw this paper and it caught my attention, because even 10 years after my training, I was still struggling to treat children with growth hormone deficiency because of its non-availability. It was not freely available. And you may all know that we were using only pituitary derived they extracted growth hormone from cadavers, and it was so difficult, and this was only practiced in Western countries and certainly not in India. And subsequently, growth hormone became available. And even today, I'm struggling to treat children with growth hormone deficiency because of it's so expensive. Even though the high costs involved has steeply fallen now, even middle-income families in our country today find it very difficult to afford this treatment. So will we be able to produce growth without growth hormone? That's why this title caught my attention. It's almost like asking, can I get a salaried job without doing any job? And so I took this paper and I read it, and you can see it's dated 1980, 1996. And he's talking about this phenomenon being known for almost 30 years, even before that. So how did it happen? How did the concept come in? And I found the conditions in which you can get normal growth without administering growth hormone, even though they are growth hormone deficient. And the patient who caught their attention was post craniopharyngioma surgery, and number of patients had been reported by that time, and all of them had craniopharyngioma surgery, and subsequently number of reports also arrived on the scene where they described cellular, supracellular, and hypothalamic disorders with multiple tumors only. Most of them are tumors. Then, my interest was deflated. I'm not dealing with tumors because in children, as you all know, tumors are not very common, but short stature is very common. Growth hormone deficiency is much more common than this. And so I was thinking, what is the idea? Then the author goes on to explain that in fetal life, we know growth hormone doesn't play a big role, and the fetal growth factor is often thought to be insulin, because hyperinsulinemic infants of diabetic mothers are large. You all know that. And hypoinsulinemic infants, as in pancreatic agenesis or leprosonism, they are supposed to be very lean and not well grown. Their growth retarded. We all also know that obesity, just now Shaila was also saying, they are definitely taller than the 50th centile, and they show a concomitant increase in height velocity in association with acceleration of epiphyseal maturation also, that is advanced bone age. However, ultimately, obese children will stop growing in height prematurely, which fits in with their degree of advanced epiphyseal maturation. And obesity-induced hyperinsulinemia is often the cause. We also know that in endogenous obesity, such as Cushing syndrome, they present with short stature. And here, these are the cases that were described first. You can see post-craniopharyngioma resection, the child has put on weight enormously, and that has helped him to grow also. And so the clinical situations I've already told you about obesity and all that. But there is one line here which says otherwise normal children. That's what was interesting to me. And then I read up about the proposed mechanisms for growth without growth hormone. And I've mentioned these already. And there are so many other hormones like prolactin, growth hormone variants, IGF-1 and 2, and several growth factors. They were all described. but it still didn't help me. How can I treat children without growth hormone? And is there a shortcut? And that's what all the parents will ask you when you say growth hormone therapy is what is required and you have to treat for this number of years. They will say, I cannot afford. Is there any other treatment, alternative treatment, they'll ask. But even in 2003, in the 21st century, there was this paper which talked about growth hormone uh, not being given, but growth achieved. And the growth pattern and final height of 5 patients were described in this paper. And they all had idiopathic combined pituitary hormone deficiency. And I must also tell you, when I talked about the other cases several decades ago, they didn't even have proper growth hormone assessment techniques. But in this paper in 2003, they had all the advanced technology. They assessed or assayed growth hormone and proved that it was not only growth hormone deficient, all multiple pituitary hormone deficiencies were also described. And but still, these children have grown quite well. My slide is, yeah, sorry. And these are the 5 patients they have described in this paper. And you can see all of them have grown quite well. Of course, they received thyroxine, hydrocortisone, and even gonadotropins and all that. But growth hormone, though it was deficient, growth hormone therapy was not given. And all these 5 patients have improved. Why did they improve? How did they improve? They don't know. At the end of the paper, the author still says the reason still remains elusive. So I might have tempted a lot of people to attend my lecture saying growth without growth hormone, and you might have thought I'm giving an alternative therapy or something like that. But I'm sorry, I have to disappoint you. But my idea was to tell you that where children can be helped, where they can be picked up, diagnosed, and we can, uh, by just assurance, we can help them to grow. Okay, I'll come to that in a little while, but in general, normal growth in children is a highly complicated process. And because it involves the interaction of genetic, nutritional, environmental, and hormonal factors, predominantly growth hormone, but there are other hormones also which are important in growth. And in growth hormone deficiency, there is definitely growth retardation, short stature, delayed bone maturation, and reduced growth spurt during puberty. So in isolated growth hormone deficiency or combined deficiency, these are the hormones that are deficient, and these are the ones which need to be uh, looked at and treated. And evaluation of short stature, all of you know, and I wanted to make this slide a little less complicated by showing you that anybody who has got a height uh, less than or more than 2 standard deviation below the mean for age, height velocity less than 5 centimeter per year, and height more than 2 standard deviation below the mid-parental height. Those people are the ones who require to be investigated, and we need to rule out simple things like hypothyroidism and endocrine causes as well as GI causes. And we need to also rule out whether they are disproportionate. And if they are disproportionate, you know it is skeletal dysplasia. If they are also dysmorphic, it may be things like Down syndrome or Turner syndrome. So that leaves us with the proportionate children who are not dysmorphic. And again, there is a large chunk of endocrine conditions, which we will not deal with today. But there is an equally large proportion of cases which come under the category of idiopathic short stature. And the 2 main categories which are included under idiopathic short stature or constitutional delay of growth and puberty and familial short stature. And they both have height velocity more than 5 centimeters or 5 centimeters. And they are growing normally, but at a lower centile when compared to the others, their peers. And in constitutional delay of growth in the and puberty, the bone age is delayed. Whereas in the case of familial short stature, the bone age is normal and their predicted height is equal to the mid-parental height. And now I'll come to the case history of my patient, who's a 12-year-old boy, and the parents were both doctors, and they were referred for the concern of poor growth to me, and he had no sign of puberty, whereas he was worried that other children in his class were already having facial hair and all that. But he had no other complaints. His birth weight was 2.5 kilos, and it was no significant factors in his past history. And he was studying quite well, and he was a very active child, playing basketball, and he was a taekwondo black belt candidate. And there was no family history of short stature, by which I mean nobody was less than 5 foot. But mother herself was just 5 foot. And father was quite tall at 176 centimeters. And mid-parental height was 176 centimeters. And the father, on repeated questioning, he finally came up with the history saying that he was short in school and he sat in the front 2 benches always, and he had late onset of puberty. And he was growing late, and after the onset of puberty, which itself was delayed, he grew suddenly and reached the present height. And you can see that he is 176 centimeters, which is quite good. And I was also digging into the family history when he said that his father also gave a similar kind of a history. And that was a very, very useful clue to me. And I'm sure all of you have guessed by now that the diagnosis is not growth hormone deficiency, but it is constitutional delay of growth and puberty. And when I examined, he was a very alert, active boy, and his height was in the less than the 3rd centile, and his weight was in the 10th centile. He had no dysmorphic features, proportionate, and he was prepubertal. Testis was 3 ml, and he was not hypogonadotrophic, but he had appropriate testicular size for that age, although I would have expected him to enter into puberty at this stage when his testes should be 4 ml. Systemic examination was normal. Because parents are both doctors, and mother being 5 foot, she was very concerned, and she kept a meticulous growth chart, which was very useful for me. I always hope that parents will have some growth charts, but they never have any previous charts, even though they might have gone to the doctors, and quite a number of pediatricians have recorded their heights, but they will never come up with anything like that. And this boy had a height velocity of 5 centimeters per year, and screening investigations were all normal. His bone age was 10 years, so there was a delay of 2 years. And these are the laboratory investigations which I had done, and these are the ones which are required in a patient with short stature. All of them were normal. I didn't bother putting all the values and straining your eyes. The bone age, I told you, is a regular investigation that we do, and it was two years behind his chronological age. Karyotype we don't do because he's a boy, and skeletal survey was not required because he did not have any such abnormality. And this is the growth record which the parents had kept, and I could make a beautiful chart with this. And you can see that he's growing all along in a normal fashion with a normal height velocity and close to the regular centile charts. And these red dots indicate bone age, which was always delayed by around 2 years. And as he was growing, I mean, I wanted it every year when they're doing it so nicely. He came to me at the age of 10, I'm sorry, 12, which is here. And they had one X-ray previously, but because they are doctors, they know that exposure to X-rays are not good. They didn't want me to do many. And here, when the gap reduced to 1 year, they stopped. And he has already reached 175 centimeters, which is very good. And you can see that the mid-parental centile is here, and he's even better. And he had delayed puberty, and that gave him a good start to grow faster, and he has reached the normal height potential. And hence, this is a case of constitutional growth, delay, and puberty. And it's a happy ending. No money involved, no treatment, no daily injections, but he has achieved his normal growth potential. This is a very common condition, but we need to take the history and find or establish the fact that the height velocity is normal. Constant, regular growth hormone, growth monitoring is very important. And only when they come regularly like this, we can assure them, and you can also be sure that this is not something which requires very expensive treatment or any treatment at all. We just want him to lead a healthy life with normal exercise and so on, and he will grow. And I just complain that parents don't keep any height record. I just wanted to share with you a grandfather's record of his 3 grandchildren. Every year on the same date of the year, he has recorded, and he has even calculated the height velocity. Can you see that? He was so useful, and I had to convert it into centimeters to draw the growth chart of this patient. I wish all the parents will be like this. And this is the patient's chart, and we have made a diagnosis of constitutional growth delay and puberty. So my appeal to you today is to recognize this. And this is, of course, done by exclusion. We need to make sure that the child, if the child is growing properly, sometimes they are worried, and you will have to demonstrate to them that the child is all right. And some parents are very over enthusiastic, and they expect their child to be 6 foot all the time. That's not possible. So if the growth failure is defined as more than 12 years in boys and more than 10 years in girls, if they are having growth failure, you need a very careful medical history, family and past medical history, and chronic conditions need to be ruled out, like malnutrition and recurrent illnesses and so on. And consanguinity is also equally important. We need to take birth history to rule out short for gestational age, prematurity, and so on, because they can also affect the growth. And abnormalities of fetal growth and perinatal complications, and even the history, as I told you, about the timing of puberty by the parents or first degree relatives. Sometimes it may be a cousin, even mother's first degree relatives, and mother or father. And those things are very important to confirm the diagnosis of constitutional delay of growth and puberty. It goes without saying we should do a complete physical examination to rule out any dysmorphic features, abnormal body proportions, and pubertal staging. That's very important also. And if we do all that, it is quite easy for us to make a diagnosis of constitutional delay in growth and puberty. Some of these children who are short are affected psychologically because of bullying at school, discrimination faced by them in their atmosphere, and those also have to be elicited by us. And it's very important to obtain all previous growth data, but unfortunately it may not be available. If it is available, we should mark them on the appropriate chart. Here again, I would like to appeal to all the pediatricians that we need to look at growth and also plot them on the growth chart. And all of you do weight recording when a patient walks in, but height is not regularly done. But there are some who are very, very meticulous, and they help the pediatric endocrinologist. Now, in contrast, this is a case of familial short stature. And here again, you can see the growth velocity is quite good, normal, but they have only a reduced family potential. And so they can only reach that much. And here again, no treatment is required. And even if you treat, you're not going to achieve much when the genetic influence is so strong. And I want to just show you, this is the height velocity chart. And if you see, that's the normal height velocity, which is associated with puberty in girls. And the next one is in boys. And the third one, C, marked C, is the constitutional delay in growth and puberty. So the puberty is quite markedly delayed. And this needs only observation as long as there is no systemic abnormality. And the next chart shows you how a child with growth hormone deficiency will fare. They do quite well in the beginning, and then they grow for a while, then flatten out. And this growth chart plotting itself can give you a diagnosis straight away. And I just put up some differences between CDGP and familial short stature, which is also called genetic short stature. And as I told you, the birth weight, length, and height velocity are all quite normal. Initially itself, in the first year itself, they show a catch down growth. Both of them show a catch down growth, unlike growth hormone deficiency, where they grow quite normally in the beginning, and then they tend to flatten out or cross centile downwards. And they always have slow height velocity, whereas these two conditions, which are classified under idiopathic short stature, they have normal height velocity. And when you plot them, you have already seen that in CDGP, they are close to the third centile, whereas in familial short stature, they may be quite markedly below the third centile. And in CDGP, the puberty is late, whereas in familial short stature, it is normal. And bone age delay is always characteristic in CDGP by about 2 years, whereas in familial short stature, bone age is always equal to the chronological age. And the final height reached is quite normal or even higher. I have seen some of the CDGPs growing up to 6 feet also. And you saw in my own patient, he has exceeded the mid-parental height prediction. that we made. And in the case of familial short stature, the final height is only around the third centile or just above the third centile according to the parental mid-parental height. The nutritional status is adequate. They are both healthy and active, and there is no problem there. Whereas in growth hormone deficiency, they may have a bit of lethargy, although it's not always, but there may be some signs that they are not strong as the others. And whenever you are faced with a situation like this, especially in CDGP, they are usually brought for the absence of puberty, not so much for short stature, although both can be there. The parents bring them, most often boys. In girls, CDGP is a bit rarer, but it can happen in girls also. And when they come at this stage, in case there is any doubt or there is no family history of CDGP, you may have to investigate them with growth hormone stimulation tests. And in this peripubertal age, you should do primed growth hormone stimulation test to avoid misdiagnosis of growth hormone deficiency. I just wanted to remind you about that. And in SGA, the majority will catch up. And I mean, Western figures are 80%, 90%, and so on. But in our setup, it doesn't always happen. But some of them may not catch up at all. And especially if they are also preterm, the catch-up rate may be a little less. And so, how do you treat constitutional delay of growth and puberty? Only treatment that is required is to provide reassurance that growth and pubertal development will occur. And this is a case where you do masterly inactivity and watchful expectancy. The final height will definitely be normal, and it is relative to the parental heights or even higher than the MPH. And the history of first degree relative getting affected is very, very important. And in some cases where the puberty is severely delayed, we can give short-term sex steroid therapy. And that is done only the if the bone age is above, sorry, this has been reversed. If the bone age is 12 or more, that's a typing error here. Only if the bone age is 12 years or more in boys, then you can give sex steroid therapy just to give a booster kind of a induction. 50 to 100 milligram testosterone monthly in boys for 3 to 6 months. And if the pubertal signs appear and they progress even after you stopped treatment for 3 months, then you confirm the diagnosis of CDGP. And on the alternative, you can try oxandrolone also. It's a weak androgen, as you all know, and it has got greater metabolic activity than androgen property. And so it can be given both in boys and girls. As I told you, CDGP is rare in girls, but oxandrolone can be used in girls in case the delay in puberty is quite dramatic. And we can give ethinyl estradiol or as an alternative, conjugated estrogens, which I have mentioned here. Again, just like in the case of testosterone, if this estrogen therapy helps them to go into puberty, and even after you stop the treatment, if they continue to remain in puberty, that means you have confirmed the diagnosis of CDGP. Here is a patient who has been treated a little longer, about 13 months. This is the period of oxandrolone therapy, and you can see that he has grown quite well, although his bone age remained backward, and the gap is narrowing there, and he is coming into the normal range. So long-term growth hormone treatment is not useful to improve the final adult height. You need to think of simple, effective, and cheap androgen treatment, which will give you quite good results. Some children may present earlier itself, even they are identified even before the delayed puberty is a concern. And in such cases, oxandrolone can be used, but unfortunately, it's not freely available now after the misuse by Olympic athletes or international athletes. We say that CDGP is a normal variation of growth and development, but it has got its own psychological and physical consequences. And one common finding is the short sitting height. How does that happen? Normal vertebral growth occurs at an early age in general, and this may not be achievable in children with delayed puberty. So the sitting height definitely is affected, and the proportions may be a little out of place. Although the final adult height is not increased with androgens in boys, with the CDGP, if you bring the timing of puberty into the normal range, that might permit a greater final stature than with extremely delayed puberty. Waiting, you may lose out on this score. And bone mineral density, there have been some reports, but generally everybody agrees bone mineral density is not affected in CDGP. So therapy in CDGP should be based on emotional and psychological impact, not on oxological parameters. Height velocity is very important. If it is normal, you just wait. And early treatment may be warranted if there are psychological reasons. And that is to potentially minimize, there is some physical advantage also, because it potentially minimizes the segmental body disproportion that accompanies significant pubertal delay. Now, what do you do for familial short stature? I have said that there is no treatment required. And here, people have tried treatment, but growth hormone therapy in one study showed only a marginal increase in final height by 2.5 centimeters. Here, it should not be given also. And it did not justify exorbitant cost and the hazards of long-term treatment. And we are not able to do a proper study because of insufficient numbers, lack of controls, different doses of growth hormone, and maybe there are some underlying pathological conditions which are remaining undiagnosed. Ultimately, FDA has not approved growth hormone treatment for this condition, and at the moment it remains an off-label use only. The psychological causes again may be exaggerated because it's not universally always associated with psychological issues. And there was a study in the UK where they did a community study, and they found, they picked up all the short stage children and they did a community study. Whereas the psychological issues are usually seen in the clinic patients. Whereas in the community, no definitive cognitive, psychosocial or maladaptive dysfunction was noticed. So this may vary from individual to individual, and psychological issues are not always a must. Thank you.
Thank you very much, sir, for that wonderful presentation. There are a few questions in the chat box, sir. Dr. Mahadevan has asked the efficacy and safety of biosimilar growth hormone in Indian children.
We have the equally good results, so we can use that, and I have used it and I've got good results also.
Okay, sir. Can we, and Dr. Arunachalam from Nagarkovil has asked whether we can increase the height by special exercises.
This is what everybody will ask you. Okay, plays basketball, will the height increase? Or if he is hanging down from the exercise bars, all that is not correct. Any exercise is good, and there are no special exercises. I'm sorry to say there are no special.
No exercises. Yes, sir. Okay, sir. Dr. Nedunjulian wants to know whether if when we have a regular growth monitoring and we can identify the cause at the earliest and have the appropriate intervention, we can achieve the normal growth without administering growth hormone.
Definitely, growth hormone deficiency. You'll have to pick up quite early, and if you treat early, the ultimate results are very good. And there is a study which shows that the sibling of an affected child was picked up earlier and treated from that age itself, instead of the first one who was picked up later. And the first child reached only the 25th centile, whereas the second child, because of continuous treatment, early treatment, became much, much better.
Better. Okay, sir. One question from my side, sir. The right age to start testosterone in CDGP, constitutional lane growth and puberty, 14 years, 15 years, 16 years?
I told you, around 12 years also you can start. And it can give them a better start. And but it is only for a few months.
Okay, 3 months, 3 to 6 months, as you said.
And if there is no improvement, I don't think we should continue that. That's why oxandrolone was preferred. When I was working abroad, I was using oxandrolone without the side effects of androgen therapy. It can fuse the bones early. So oxandrolone is much, much better. But
okay, sir. One last question, sir. With your vast experience in children with CKD, chronic kidney disease, how much growth is anticipated with correction of acidosis and anemia, sir?
I can't answer that question because I have not had much experience in that line.
Okay, sir. Okay, sir. Thank you very much, sir. Thank you for answering all our questions patiently, sir. We had a real wonderful session. Thank you very much, sir.
Now we stop sharing the slides.
Yes, sir. Thank you.
How do I stop sharing?
Stop.
You already stopped, sir.
Stop sharing, sir. Now we'll move on to the next session. Anthropometry in Indian children. What is new? All of us would we are really anticipating what Professor Dr. Vaman Kadilkar sir is going to talk to us. As we all know, Dr. Vaman Kadilkar, he conceptualized and designed the IAP growth charts in 2015 and many Indian anthropometry norms. He is a consultant pediatric and adolescent endocrinologist of Jahangir Hospital, Pune. Dr. Vaman Kadilkar was a past president of Indian Society for Pediatric and Adolescent Endocrinology. He has got a doctorate. He is a PhD guide for Pune University. He was trained in pediatric endocrinology at Great Ormond Hospital, London. He is editor-in-chief of Indian Academy of IAP textbook of pediatric endocrinology. He is a national convener for our growth monitoring guidelines of Central IAP 2007 and the national convener for calcium and vitamin D guidelines. Over to Dr. Vaman Kadilkar.
Thank you, Lakshmi. And first of all, I would like to thank Tamil Nadu IAP for arranging this wonderful seminar and giving me an opportunity to present my work. So before I start my talk, I wondered if I could answer that Dr. Mahadevan's question about the biosimilar growth hormone. See, we have written a paper in Indian Journal of Endocrinology and Metabolism about 2 years ago, where 337 children have been compared on biosimilar versus the innovator molecule. And there's absolutely no difference in the response, or there's absolutely no difference whatsoever in terms of side effects. So I'll now move on to my talk. And let me just tell you that you guys have been seeing a lot of endocrine lectures in the last few days, especially because of the Zoom platform. I think it's a wonderful platform. And
We are getting more and more used to presenting on Zoom platform, and I think people have managed to maintain their interest. And you do see all my senior and junior colleagues presenting a whole lot of charts. You see CDC charts, you see Tanner charts, you see the old IAP charts, and happily to say that you are seeing more and more of the new IAP growth charts. So what I am here today to tell you is what our Honorable Prime Minister's Make in India move. So I'm actually going to show you the anthropometric norms that our team in Pune has been able, along with the help of IAP, to produce many Indian anthropometric norms. So that's what this talk is going to be all about. So let me share my screen now. And hope you can see my slides now. Can you see?
We can.
Okay, fine. So that's the place where I work, and that's where we have our research institute from where all these papers come out. So moving on, let me first tell you what are growth charts, and more importantly, like the under 5 mortality speaks of health status of a nation, a growth chart speaks of health and disease in a child. Hence, they are also known as road to health. Now, it's such a powerful tool. You just heard Professor Raghupati quoting some of his experiences from Australia. And anthropometry is such a powerful tool in the hands of pediatricians and endocrinologists that in Australia, you actually do not even need a growth hormone stimulation test to start growth hormone on a patient. You actually need the anthropometric proof over a period of time. That is the importance of anthropometry. Now, normally, what parameters do you as pediatricians assess? You assess the height or length, weight, head circumference in the first 3 years, body mass index, upper and lower segment, waist circumference. You heard Dr. Shaila speak of waist circumference. And other things such as, say, skin fold thickness or wrist circumference can be either clinical or research tools. Now, anthropometric data collected over several thousand of children makes it possible to produce growth charts. So primarily, your growth charts are graphical representation of statistically smooth percentile values. And growth charts are much better as compared to your tables, because in table, there is no continuity, whereas in charts, you get a very good visual impression of the actual growth curve. So it is best to use growth charts and not tables like about 20, 30 years ago, some pediatricians used to use. But let's first understand our charts. Now, you all know that these are the IAP simplified WHO growth charts, where the IAP has given you the length, head, and weight parameters on a single page. Whereas if you download them from WHO website, you will have 8 pages if you take 2 sexes together, or 4 pages per child. So what the chart actually shows you is the length, head, and weight, but there are 4 lines, unlike the 7 percentile lines that you see in the original WHO chart. So these have been simplified. But more importantly, the average line is in the middle. The top line is the 97th percentile or the +2 Z-score. And the orange line is -2 Z-score. And the red line is -3 Z-score. So you have upper limit of normal, average, lower limit of normal, and very abnormal. For the head circumference, however, only the 3rd percentile has been depicted, because I think you're not really supposed to wait until it drops below the 3rd percentile. For weight, again, you have 2 similar lines. The orange is the -2 Z-score, and -3 is the red line. Now, a lot of us do not somehow use the weight for length or height chart. But please remember, these are the BMI equivalent of older children. So whenever there is a child with failure to thrive in question, you must surely look at these charts. Now, as you know, these are age independent. What you need is the length on the x-axis and weight on the y-axis. And again, you have 4 lines. The top line is the 97th percentile. The middle line is the average line. And the orange arrow is the -2 z-score. And the red is the -3 z-score. Or what WHO defines as moderate acute malnutrition is the orange line, and severe acute malnutrition is the red line. But I would like to remind you that somehow on WHO's booklets and website, it's very clear that MAM and SAM terminology should not be used in the first 6 months. They're usually reserved for children beyond 6 months of age. So these are the IAP growth charts from 5 to 18-year-old. You have 7 percentile lines here. Again, the top line is the 97th or +2 z-score, 0 z-score or 50th is the average, and -2 z-score or 3rd percentile is the lower limit of normal, and same is true for weight. However, the BMI charts, and you did hear Dr. Shaila speak about this, that for the BMI charts, you actually have 2 different lines. They are overweight lines and obese line. But how are they defined? They are defined as 23 adult equivalent and 27 adult equivalent respectively. Now, why 23 and 27 and not 25 and 30 like in the WHO chart? The reason is, somebody did ask this question in the earlier lecture, the YY paradox. See, an Asian Indian, that's us, we actually are much fatter at a given BMI. What it means is that the proportion of body fat in Indian children is much higher as compared to the Caucasian children at a given BMI. So you need to lower the BMI cutoff so that you pick up the metabolic syndrome variables at a lower BMI. So this is WHO's recommendation that for Asians as adults, you keep 23 for overweight and 27 for adult. And the IAP has provided you with the children equivalent of that by statistically fitting these lines. Now, as I said, how do you assess growth? Use growth charts. Charts are better than tables. But as Dr. Raghupati again and again in his talk very elegantly showed you, that longitudinal data plotted over a period of time is far more valuable than a single isolated reading. He could only diagnose CDGP because of the longitudinal plotting of the data. Another important consideration is to take birth weight and gestational age into consideration when you plot growth charts in young children. Up to 2 years of age, you should correct for prematurity, and beyond 2 years of age, you do not need to correct for prematurity. Now, you all are aware that in 2015, the Indian Academy of Pediatrics wrote these guidelines, and they also gave the revised IAP growth charts for height, weight, and body mass index for 5 to 18-year-old children. And I just showed you those charts. So that just, once again, the graphical images of what is available. All these are available on the web. You can download and use them. For routine clinical use, you do not need any permissions. Now, the next question is, how do you adjust for the mid-parental height? Now, the way you adjust for mid-parental height, which is also known as the adjusted mid-parental height or target height, you take mother's height plus father's height plus 13/2 in centimeters, and for girls minus 13/2. And then you plot it at 18 years of age on the chart. And the mid-parental range is taken between 6 to 9 centimeters above and below the target height. Now, this 6 to 9 range comes from +1 SD, +1.5 SD, or +2 SD around the mean. Let us look at an example. Now, here is a kid who is on the 3rd percentile, as you can see on the graph. Now, his weight is also below the 3rd percentile. So we plot his height and weight. So that's where his mid-parental height is, and that's the mid-parental range here on the right side of your screen at 18 years of age. And now, using your drawing skills, you can actually draw a percentile, which is the lowest percentile for this family. Now, when you use 6 centimeters as the spread, you have 10th to 90th percentile for this particular family. So you are now creating a specific chart for this family so that all boys of this family should fall within these 3 percentile lines. That's how you correct for mid-parental height. Now in 2021, we produced the pediatrician-friendly growth charts. And these charts are particularly useful because we have eliminated all the calculations from your chart. Now, I fully understand that pediatricians are a busy lot. Doing calculations is difficult. Calculating BMI is one more step, or calculating mid-parental height is even further step. So what we have tried to do now is to give you 2 tools on the existing IAP charts. This tool, which Dr. Shaila briefly touched upon, is called the Quick BMI Lookup Tool and is applicable for children between 8 and 18 years. And this is to calculate the mid-parental height. Now let us see how it works. Now see, no calculation is going to be required here for BMI, and no calculation of MPH is going to be required here. Let us see how. This is the BMI tool. So all that you need to do is, just like I showed you weight for length in under 5 children, you plot the weight on the y-axis for the given height on the x-axis. And let's see how it works. Let's take the first example. You have a 135 centimeter boy who weighs 30 kilos. Now you can see by joining these 2 axes, you get a dot here. So this child falls within the normal range. The same height, but weight of 35 kilos. And you see she now falls in the overweight range. If the same child with a height of 135 had a weight of 45 kilos, then she falls now in the obese category. And if at the same height, this girl had a weight of 20 kilos, she becomes underweight. So these quick BMI lookup tool for 8 to 18-year-old children makes it very easy to use a screening tool to quickly see, am I looking at a patient who is obese, like Dr. Shaila showed, a child standing there with a t-shirt on, you will not sometimes understand that this child is actually obese. But plot it on the tool and you will immediately recognize that this child is abnormal. And similarly, let's take an example of a mother who is 157 and dad who is 170. By using our calculations, we know that the mid-parental height is 157. How does it work on this tool? Father 170, mother 150. All that you do is you join these 2 points. And in the middle, you read that now the mid-parental percentile is between 25th and 50th and is closer to the 50th. So you can quickly look at the child. And if the child is below 2 major percentile lines, as compared to the percentile given here, you know that the child is abnormal. So the same thing plotted here on the growth chart, that's where the girl's height is, that's where the weight is. Using our BMI tool right here, you don't need to do any calculations of the BMI. You straight away look it up here. This child is obese. And the mid-parental height, which I got from the calculation here, is plotted just under the 50th percentile. And by joining these 2 numbers, here again, you have a quick lookup tool for MPH that shows you the same. So in the pediatrician-friendly growth charts, the IAP has eliminated all your calculations. So it has made, I hope, life simpler for the pediatrician in a busy OPD to look at these 2 parameters. Now, you looked at the height velocity, which Professor Raghupati showed. Now we have the Indian height velocity chart. We have been following J.M. Tanner's charts for many, many years. And in last few years, we have done longitudinal study for 7 years across India. And we have produced the Indian growth velocity charts, which are published in Indian Pediatrics in 2019. So you now have Indian growth velocity charts for boys and girls. And if you compare them with Tanner, the mean height velocity is a little lower in Indian children, particularly so in case of girls. And just a reminder that on growth velocity charts, your cutoff for danger is 25th percentile and not the 3rd percentile like in normal distance growth charts. These are the simplified height velocity based on those charts. Is in the first year you grow 24 centimeter, second year 12, third year 6. In the 4th year, till puberty, you grow about 5 centimeters a year. And in puberty, it is anything between 8 to 12 centimeters, and you should refer to those velocity charts. Now, you heard Dr. Shaila speak of obesity. Obesity is a pandemic, and it's going to be worse with the lockdowns. These are the old figures, and I think Dr. Shaila also showed the same figures. I have already mentioned this, so I'll skip a couple of slides, and I'll straight away go to the danger of metabolic syndrome in adolescents. Now, see, Indians are particularly prone for metabolic syndrome because of their propensity to have central body fat and relatively low lean body mass. But there are about 10 definitions of metabolic syndrome available in children, but the most accepted definition as of today is the IDF. And as you can see, there is a paradigm shift. There is a paradigm shift in the way metabolic syndrome is defined in children, that the primary starting point is the waist circumference. And in the recent update, it's very clearly given that you either use above 90th percentile for NHA-NES for countries where no waist charts are available, but for countries where there are appropriate ethnic charts available, please use those. And then presence of 2 or more of these 4, that is hypertriglyceridemia, low HDL, hypertension, and fasting impaired glucose. So we have actually produced the Indian waist circumference charts, which are published in the American Journal of Pediatrics in 2014, and this is the paper. And these waist circumference charts look like this. You have charts for girls and you have charts for boys. And we have highlighted 70th percentile instead of 90th. The reason is our study actually showed, which has been echoed by some workers like Dr. Anurag Bajpayee and Himchand Prasad, is that at 70th percentile of waist circumference, you already start showing the metabolic risk factors. So maybe it's okay for a Caucasian child to stick to 90th percentile, but in India, perhaps we will even have to lower the waist circumference. Now, proportions. We all have grown up as pediatricians learning that at birth, the upper segment, lower segment ratio is 1.7. It becomes 1.3:1 at 3 years. It becomes 0.9 at 9 years and becomes nearly 1 after adolescence. This is based on the Caucasian data. Now, India is a vast country with so many ethnic variations. Is this true? So we have now produced Indian upper segment, lower segment ratios, as well as we have produced sitting height and subischial leg length chart for Indian children, which are published in the Annals of Human Biology. And you can use them for Indian children. What is important to remember is that the discrepancy between the upper segment and lower segment should be more than 2 standard deviation on the charts to say that my patient has disproportionate short stature. Now, in 2020, we wrote this paper in Journal of Pediatric Endocrinology and Metabolism, the European journal, and we have produced extended growth charts. These are of particular use for pediatric endocrinologists and endocrinologists. Now, these are needed for diagnosis of severity of short stature. They are also necessary for deciding when to treat a child who has short stature due to SGA, idiopathic short stature, and syndromic short stature. So these are the extended growth charts where we have given you -2.5, -2.25, and -3 Z-score on the existing IAP-WHO combo charts. So here you can see that the red one is for severe syndromic short stature, the orange one is for SGA, the dark brown is for SGA, and the orange one is for idiopathic short stature. So you don't need to go back to your IAP spreadsheet and calculate the Z-score. Here you can directly get it just by plotting on the growth chart. So extended growth charts are very useful for people who are pediatric endocrinologists and endocrinologists. Now, why we have produced these charts? Why Indian? Why I'm saying make in India? Now look at this CDC charts, third percentile for a girl versus the Indian third percentile. If you are going to produce or treat a child who is below the third percentile based on the CDC chart, see how many more children you would unnecessarily treat. How many more children you would unnecessarily treat. So you should use Indian data while deciding whether your patient actually qualifies for treatment with growth hormone. That's the American third centile, and that's the Indian third centile. Now I'm going to take you on a short journey of something very new and novel called the synthetic growth charts. Now let me first introduce this concept that variations in the human growth have been attributed to genetic, nutrition, and health-related and socioeconomic circumstances. Despite all this, human growth curves across the world show certain common characteristics. Therefore, a very large global database was set where more than 200 studies over the last 50 plus years was constructed, and regression equations were designed from this global data to determine the median for height and weight at all 5 key ages. And then, based on that global database and the regression equation, you can load the country's specific data points onto those equations and produce your growth charts. But you also need to have the spread. Now, as some of you may know, height is a normally distributed variable, whereas weight is actually a variable which is skewed to the right. So you have to have what are known as the LMS values, which are produced from the global data. That is your lambda, your mu, and your sigma, which can help you to produce country-specific percentiles. I would just like to ask the administrator, why am I getting these lines on my screen? I think somebody else's screen is active. Can you please delete those yellow lines which are coming on my screen?
So actually, I don't think any other screen is active either.
Okay, but now that line is gone, so somebody is playing with it. Yeah, and even that yellow line has been sitting there for a while. But anyhow, let's move on. So the basic components that you need to produce growth, synthetic growth charts, are you need only these parameters at these key ages, which are birth, 2 years, 6 years, 12 years for girls, 14 years for boys, 15 years at girls, and 18 years for boys. Now, why am I telling you about this exercise? The reason is, in a country like India, which is so vast, producing charts requires an unbelievable amount of effort to keep on collecting data decade after decade after decade, and that too over people who grow in the good nutrition and good health. So it all then becomes a private exercise. No government agency is doing this for you. The NFHS survey, if you look at them, even the most recent, the representation of the well-off people is not even 5%. So you cannot produce growth charts from that data. So then if you have to collect 100,000 children's data across India like we did in 2007, it becomes a huge exercise. It's very cumbersome, it's extremely expensive, and to be honest, it's not possible decade after decade without any government funding, and government is least bothered about giving you any funding whatsoever for producing your own country's references. Hence this method. What this method actually gives you is that you only need to have means of representative sections. So limited data taken on the right population and just plug it into the global model. So let's move on. From this, you produce these means for weight and height. And then using complicated regression equations, which are nonlinear regression equation, you join the means. So you then have the country-specific median curves for weight and length. Now you smoothen these medians using Priest-Benz equations. Now Priest-Benz modeling, I won't go into the detail, but these are some of the most well-fitted models to human growth. So if there is any aberration in your statistical prediction, these models will correct it. And for under 2 years, you use the Jolly Core model. So putting these two things together, you then smoothen the growth curves. And then you use global LNS values to produce the weight and BMI, and global LMS values to produce this height charts. And this is what you get. So you get this beautifully designed charts just based on representative data of your country, and you don't have to do the mammoth exercise of collecting this data again and again and over again. This will also show you your country's secular trend because you are putting the local parameters on the global model. So doing all this, we produce the synthetic growth charts for Indian children, which are published in the Indian Journal of Endocrinology and Metabolism in 2019, December. And for all those who are interested in seeing the difference between IAP growth charts and the synthetic growth chart, here is the paper which is very freely available. And interestingly, there's almost no difference between the IAP charts between 5 to 18 and these charts. But the strength of these charts is that here you have 0 to 5 years Indian chart. Because as pediatrician, 90% of you will agree with me that on WHO growth charts, nearly 30% of children in the urban area and 40 to 50% of children in the rural area are below the 3rd percentile for length and weight on WHO charts. So let me show you an example here of how it works out when I look at 2 children with failure to thrive. Now let's take example of this 12-month-old boy with a length of 72, weight 7.5 kilo, and another boy who is 36 months, 90 centimeter, 11 kilos. Now let me plot here. I have plotted the first boy. His height is on the 3rd percentile. His weight is on the 3rd percentile or just below the 3rd percentile. And the second boy's height is just above the 3rd percentile and the weight is below the 3rd percentile. And for weight for length WHO chart, both the children are actually failing to thrive. They are below the 3rd percentile of the WHO chart, or what is known as the moderate acute malnutrition. Now we thoroughly investigated these children because they are man. All tests came back normal. Their parents are not very tall and the family is slim. Now we put the same data on Indian synthetic growth chart and this is what you get. What you get here is that in both children, they are all right for their length, and for the weight, the first one is on the 3rd percentile and the second one is the second one is on the 3rd percentile and the first one is between the 1st and the 3rd percentile. Now plot them on weight for length, Indian synthetic growth charts, and you see that both the children are above the orange line. Once again, mind you that these children's all tests were normal. So if we would have used the synthetic growth charts on these children without any symptoms, without any signs of disorders, we would not have unnecessarily investigated these children. So I'm not making a point at this time that maybe synthetic charts are better. All that I'm saying is that this possibility needs to be explored. And there are at least 120 papers today in the world literature which say that WHO growth chart, which say one size fits all, is inappropriate for majority of the third world country and a lot of even European countries. So I think this is a food for thought for you. Now there are lots of software tools which IAP has produced, and Dr. Raghupati sir had shown that data, handwritten data, which is so nicely kept by the parent. But in this day and age where young parents are so tech savvy, all that they need to do is go to the go to the Google website, download our IAP growth chart application, which is completely free. This application draws the graphs for you, it interprets for you. So parents, actually, many of my patients do plot this on their own phones and show me the growth charts. So I urge you all to encourage your patients to actually save their child's data, plot it, and next time when they come, just show you the growth chart. It becomes so easy for you. Now, we have also designed some software tools for the researcher. Those who are interested can write to me. All this data which I showed you, I have put together in Excel templates. So anybody who is doing research, maybe it's a PG student, it's a clinician, a researcher, if you want to calculate Z-score for any parameter, including even Indian systolic and diastolic blood pressure, you can just put your numbers here and you will get the Z-scores here. So this is particularly meant for researcher, but anybody can use them. We have designed multiple tools, like we have this Tanner Whitehouse scoring, and you can get a height prediction. I have kept all these tools royalty free because I want people to use them and then give me a feedback. Now, before I end, there is an Indian Society of Pediatric and Adolescent Endocrinology conference in 2021 in Pune, and hoping that there will be no third wave of pandemic, this will be a physical conference. And we have a galaxy of international speakers, and we have 3 days of Feast of Pediatric Endocrinology, which is actually preceded by a SP PET Fellow School, which is a 3-day compact, really packed program, which is going to happen at the Corinthian Club in Pune. And I urge all of you who are interested in pediatric endocrinology to register for this meeting. And last day is only for pediatrician. And this is the website, www.ispepune2021.com. Anybody interested, please register. Still, we have the early bird registration open. And should it unfortunately go all virtual, then half of your registration fee will be returned. So with that, I would like to once again thank my chairpersons and all my colleagues and friends who have been patiently listening to this, and for IIP Tamil Nadu, and most importantly, the Central IIP, to give me an opportunity to produce IIP growth charts, which will be used for pediatricians in this country. Thank you very much.
Thank you very much for that real, clear and wonderful session, sir. We are running short of time, so I'll just allow 2 questions, sir. These pediatrician-friendly growth tools are really appearing, real exciting tools, sir, because calculating BMI and mid-parental height is a real cumbersome job, and you have simplified this. And Indian synthetic growth chart, we'll have to get used to the terminology and to the charts probably. Maybe one question, sir. What discrepancy between the parental height centile and the individual height centile should we intervene?
It is minus 1.5 Z-score, but since Z-scores are slightly hard to interpret for practicing people, I would say if you have 2 major centile line discrepancies, so if your mid-parental height is on the 50th and the kid is on the 3rd or even 10th, then that is abnormal, 2 major percentile lines. And if the mid-parental height is 75th and the kid is below 25th, that's abnormal.
Okay, sir. Dr. Niranjan has asked one question, but maybe you can answer him in the chat box, sir. He has asked when we have the standard Indian charts. Okay. Now I end up this session. Thanks a lot. Really very wonderful session we had with you. I thank all 3 of my speakers, Dr. Shaila Bhattacharya ma'am, Dr. Raghupati sir, and Dr. Vaman Kadilkar for 3 exciting sessions. Thanks for patient hearing and listening. Now we'll move on to the next session by Dr. Ramasamy. I request Dr. Ahila Ayyavu ma'am to take over and continue the session. Thank you very much.
Thank you, Dr. Lakshmi. That was a wonderful expert session. You did remarkably, you really made it even more exciting. And I'm deeply thankful to Dr. Shaila Bhattacharya, Professor Raghupati, and Dr. Vaman Kadilkar for the wonderful sessions and very, very useful ones too. And I would actually encourage, again, on behalf of Vaman, for all of you to register for the ISPE biennial conference at Pune. And please do enjoy the galaxy of speakers and the sessions that would happen in Pune. Please do register. May I take this opportunity? Thank you, madam, once again.
Thank you, sir.
Now, I would like to invite Dr. M.R., who's a doyen of pediatrics in Coimbatore. Sir, I think nobody needs introduction to you. He's a towering giant and a teacher for all of us in Coimbatore.
Too much of introduction for me, Dr. Ahila. And am I audible to all of you?
Yes, sir. You're very clear. You're clear.
Hello.
We can hear you very well.
Right at the outset, I'd like to express my thanks to the office bearers of the Tamil Nadu chapter of Indian Academy of Pediatrics, Dr. Rajendran and Dr. Ismail and Dr. Gopal Subramaniam, for requesting this octogenarian, Ayiram Pirai Kandavar, to be the moderator of the session on congenital hypothyroidism and diabetic ketoacidosis. Now, 2 pediatric endocrinologists, I'm not going to give you their entire, curriculum vitae. Dr. Anna Simon from Christian Megladaloo and Dr. Ahila Ayyavu, representing 2 hospitals in Coimbatore, Kuppuswaminadu Memorial Hospital and Masonic Medical Center of Children. And they're going to share their experiences and also update us on the current state and standard of care on 2 common conditions, namely congenital hypothyroidism and also diabetic ketoacidosis. Now, suffice to say that much water has flowed under the bridge since I commenced my general pediatrics in the year 1968. After 3 years of pediatric residency at one of the city hospitals, where I was fortunate to have very liberal exposure to pediatric endocrinology problems, because my mentors were all members of the Lawrence Wilkins Society of Pediatric Endocrinology. Believe me when I tell you, and in the past 55 years of my experience, practice, I have run into the conditions which they are going to discuss on several occasions, and I have absolutely no regrets whatsoever, either in diagnosing or managing these conditions. Indeed, some of those children whom I had diagnosed and treated have all become productive citizens, parents by themselves, and also they have families of their own. If you were to ask me what would be the ingredients for such a successful recipe, I would unhesitatingly say as a general pediatrician. And also you must believe me when I tell you from 1960 onwards, I have been using growth chart on every child of mine. Now, there are 4 ingredients which I think all those who are digitally connected should bear in mind for a successful recipe to tackle these 2 conditions. The first one is very high index of clinical suspicion during the evaluation of children. And secondly, the confirmation of clinical impression by a very simple and ineffective tests which are available. And thirdly, of course, you know how to use thyroxine in congenital hypoparathyroidism, hypothyroidism, and the fluids and insulin in diabetic ketosis. And very importantly, you must have a longitudinal growth chart to follow the child up to 16 years of age. And this is what exactly I had done on all those children. However, I must give you one word of caution based on my own experience with a lot of these children with diabetic ketoacidosis. Our experience at Masonic Medical Center has shown 50% of the parents actually do not tell us the polyuria, polyphagia, polydipsia. On the other hand, they tell us the respiratory symptoms or gastrointestinal symptoms or dehydration or some CNS. So I think this practitioner should keep in mind, children may come to you with those complaints, but the underlying disease is indeed diabetes. Indeed, I would say dyspepsia, dehydration, drowsiness, dyspnea, 4 days, not be followed by 5th day, namely diabetic ketoacidosis. So that is about diabetic ketoacidosis. Regarding congenital hypothyroidism, I hope Dr. and Simon would comment on that. Now, there is no symptom or a sign that will tell me in the first few days of age, this baby has congenital hypothyroidism. Nevertheless, if you were to examine a baby at a few days, or even at a few weeks of age, there's a clinical profile that emerges that tells you the alertness is much less than usual, and the cry is not really good. The bowel movement is really not good. In other words, there is, if you look at the child as a whole, there is a clear-cut evidence of sluggish or slowed physiological responses and responses that should immediately alert you to the possibility of congenital hypothyroidism, and you should immediately get the investigation and start them on thyroxine. Of course, they are going to tell you about the imaging. We never had this imaging, but I don't think they're very mandatory. You must start them on thyroxine. Because in the words of my mentor, if you delay 1 day in diagnosing, you lose 1 IQ. If you delay 3 months, you are going to end up with a child who is really idiot. So I think these are my preliminary observations, as introductory remarks, you may call it as a moderator. Now I would request our young, bright pediatric endocrinologists from 2 institutions to share with us their experience and then update us on the current standard of care. Thank you very much. Dr.
Anna.
Welcome, Anna.
Dr. Anna.
Yeah, thank you. Let me just start by saying a big thank you to the IAP Tamil Nadu chapter organizers and the organizing committee of this meeting for giving me this opportunity. And thank you very much, Dr. Ramasamy, for the kind introduction. I'm just trying to share my slides.
Yeah, please proceed, madam.
So can you see my slides?
Yeah, we can visualize, yeah.
Okay. So this is a little update on congenital hypothyroidism. We are moving on to a little lighter study subjects and what we heard from obesity, growth, and as you said, we'll make it more simpler and slightly, not so taxing as the previous talks. So this is what happens with undetected congenital hypothyroidism. This is an 11-year-old boy who came to us very late, you can say, at 11 years, and you can all see that he was stunted, he has postphases, he's mentally retarded, his skin was so dry and ictiotic, and he actually, when we investigated, he had an ectopic thyroid. So this is the warning slide. So congenital hypothyroidism, actually, like what Dr. Ramasamy was saying, we need to detect that very early. And the clinical symptoms and signs are so subtle. So that is why screening for congenital hypothyroidism becomes very important. And early diagnosis, early treatment can prevent the severe consequences of neurocognitive delay. And so far, we don't have a national newborn screening program, though ICMR has started some programs in a few states, and even in Tamil Nadu, some districts are doing screening now. So, and if you look at the screening for congenital hypothyroidism, this is one disease which actually satisfies all the criteria for a good biochemical screening. As mentioned earlier, the clinical diagnosis is difficult in the early days because the features are subtle, and we have very good diagnostic laboratory tests. The very sensitive third generation TSH assays are available, and there is an effective intervention available, oral thyroxine given at the right time, which is cost effective also. And if we treat early, we can actually prevent neurocognitive sequelae. So congenital hypothyroidism is one of those diseases where a biochemical screening is an excellent tool for early diagnosis. We'll go a little bit about the physiology of the thyroid gland. The thyroid gland, as all of you know, doesn't work independently. It's under the control of the HPT axis, the hypothalamic pituitary thyroid axis. The hypothalamus produces TRH, and as you all know, TRH prompts the anterior pituitary to produce TSH, thyroid stimulating hormone, which then acts on the thyroid gland, and the thyroid glands secrete T3 and T4. And both T3 and T4 have a negative feedback mechanism on the anterior pituitary and on the hypothalamus. And this is a very guarded or the physiology which is very complex. Now, so as I said, because of this level of the hypothalamic pituitary thyroid axis, when you talk about hypothyroidism, even if they are congenital, I think it is good to be aware that there are two kinds mainly. One is a central hypothyroidism, where it may be either a pituitary defect where TSH will be low, then it's called a secondary hypothyroidism, or it can originate, the defect can be in the hypothalamus and TRH is not produced, then you call it a tertiary hypothyroidism. This is central hypothyroidism. Whereas if the thyroid gland fails to produce thyroxine or the thyroid hormones, it's called primary hypothyroidism. And there are multiple causes from dysgenesis, where the thyroid gland development is altered, or dyshormonogenesis, where there is a defect in one of the steps of the hormone synthesis. And there are other forms of primary hypothyroidism like a transient congenital hypothyroidism, consumptive hypothyroidism, thyroid hormone receptor defects, defects in thyroid hormone signaling pathways. These are quite rarer, and we will mainly focus on dysgenesis, dyshormonogenesis, and transient congenital hypothyroidism. So this, I specifically mentioned this because whenever we interpret the thyroid function test, you make sure if it's a primary hypothyroidism, the TSH will always be high. If it's a central hypothyroidism, we get low TSH and low thyroxine levels. So we have to keep this in mind while we are analyzing these thyroid function tests. Now, the thyroid gland development, also a little word about it, because we are dealing with congenital hypothyroidism. The thyroid gland actually starts developing very early. It's one of the first hormone glands to develop in the fetus. It starts as an outpouch of the primitive pharyngeal wall under the base of the tongue near foramen cecum, and you can see it descends and then comes to lie in the low mid portion of the neck, and it is joined by apart from the fourth branchial pouches as well to form the complete gland. It may leave a tract of the thyroglossal duct, which later can give rise to thyroglossal cyst or similar etiologies. So the thyroid physiology, one statement I have to make is that thyroid hormones have a profound and essential role in human physiology. And both T4 and T3 are secreted by the thyroid gland. These hormones actually, the effects of these hormones are mediated via the thyroid hormone nuclear receptors, where they affect DNA transcription factors and result in changing many enzymes and proteins in the tissues where it is. And most of the action is by T3. T3 is active hormone, though in the circulation serum concentration of T4 is higher than T3. Most of its activity occurs for by T3, and iodine is an essential element necessary for the thyroid hormone synthesis. So coming to the thyroid hormone synthesis, there are a few steps which I will take you through. The first and foremost step in thyroid hormone synthesis is the active uptake of iodine from the circulation via the sodium iodide symporter, as you can see. And then the second thing is the pendrin gene and the second complex of SELC26-4A. The iodide is taken into the colloid via an apical anion channel. And then this iodide is then used to iodinate the thyroxine, the tyrosine molecules of the thyroglobulin, which is present in the colloid. So the oxidation of iodide to iodine takes place with this rate limiting step where the deox-2 and the deox-A2, which is the facilitator of deox-2, and TPO helps for the coupling of the mono and diiodotyrosine molecules to form T3 and T4. These T3 and T4 are further they're taken by endocytosis into the thing and released into the bloodstream as T3 and T4. And in the bloodstream, and even after the hormones are released, monodeiodinases act on them to liberate iodine, which is then used again for thyroid hormone synthesis. So all these steps are very important in thyroid hormone formation, and any defect in any of those steps can result in dyshormonogenesis. We'll go to the actions of thyroid hormones, especially in relevant to children. We all know that the most worrying factor of not treating hypothyroidism is when they develop neurocognitive sequelae. So thyroxine actually increases myelin formation, is necessary for myelin formation, also for stimulation of neuronal cell maturation and migration, and it stimulates dendritic branching and synaptic formation. It also influences neurotransmitters, enzymes, and cell proteins, and thereby plays a very important role in CNS development and function. You can see that it is also actions on growth and development because it has direct effects on growth. It also stimulates the pituitary growth hormone synthesis. It stimulates IGF-1 synthesis and action. It increases protein synthesis and muscle growth, and also enhances the IGF-1 action indirectly on the bone and cartilage. And just like in adults, metabolic effects of growth thyroid hormones, basal metabolic rate is increased by the thyroid hormones, thermogenesis, it increases gluconeogenesis, glycogenolysis, and stimulates insulin-mediated glucose uptake, increases lipolysis and fatty acid oxidation, and stimulation of adrenergic receptor binding. So there are so many of functions that the thyroid hormones are doing, and that's so important in the human or even in the baby's physiology. Let's look at the physiology of thyroid hormones in the fetus. As you can see here, T4 and T3 cross the placenta from the maternal side to the fetus in good amounts. The fetal thyroid actually starts functioning from the 12th week, but significant hormone production occurs only by 20 weeks, so somewhere around mid-gestation. So the fetus is actually dependent on maternal T4 for having euthyroidism. So even if the child does not have a thyroid gland, thyroid agenesis, it's partially protected by transplacental transfer of maternal thyroxine. In addition, type 2 deiodinase, which is rich in the brain, increases the local conversion of T4 to T3, thereby saving the child from hypothyroidism, the fetus from hypothyroidism. You can see here that iodine is also freely transported across the placental membrane, and TRH also is transported to the baby's, to the fetal side, and this TRH is also very important in the development of the fetal thyroid. The placenta, which produces estrogens, the main part is goes to the mother, and you can see this increases the T4 and T3 and the thyroid binding globulin in the mother. Similarly, HCG from the placenta also increases T4 in the mother. This complex transfers are very important to keep the fetal thyroid status healthy. The clinical manifestations of congenital hypothyroidism, as mentioned by Dr. Ramaswamy earlier, it's very, very difficult. Most of them are asymptomatic and we pick them on screening. One of the very common manifestations is a prolonged physiological jaundice. So whenever physiological jaundice is prolonged, I think, and if the child has not been screened, we should check. Subtle signs like being sluggish, not feeding well, sleeping more than normal, hypothermia, hypotonia, bradycardia also can be picked up. But the major manifestations like macrocephaly, umbilical hernia usually come later when there's severe hypothyroidism. And I don't think that we should wait for these to appear to diagnose congenital hypothyroidism. As said before, if the baby is having a poor cry, sleeping more, not feeding, sucking well at the breast, you have a high suspicion of congenital hypothyroidism, also prolonged physiological jaundice. Now, how do we make a diagnosis of primary hypothyroidism? As you all know, when the T4 and the thyroxine level falls, low T4, there's a total T4, and low free T4 falls, there is a feedback mechanism and the TSH will be very high. So when you have a high TSH, low T4 and a low free T4, you know you're dealing with primary hypothyroidism. And thyroid antibodies, if necessary, we can do, but not usually indicated in the newborn. Ultrasound of the thyroid scan or a technetium-99 nuclear scan. It was not available early, but the advantage of doing a nuclear scan or a MAGI, I will come to that a little later. The neonatal thyroid screening stands as the best way of diagnosing congenital hypothyroidism. And ISPE has published guidelines on the screening of congenital hypothyroidism in 2018, Indian Journal of Pediatrics. You can read this up. There are two parts to this screening guidelines, part 1 and part 2. I think it will be useful for all pediatricians if they have a look at this ISPE guidelines on screening for congenital hypothyroidism. I'll take you through one case. This is a newborn born here, a girl born 2.95 kg. We do a cord blood screening because it's an institution-based thyroid screening. And to gather all the babies born here, we find that cord blood is an easy method to capture all the deliveries. Cord blood was very high. A high cord blood is always repeated after 72 hours. And at 72 hours, again, you can see that the TSH is high, the T4 is low, and the free T4 is very low. So how will you interpret these results? As said before, you all know high TSH, low T4 or free T4, you know that is primary hypothyroidism. This child had a thyroid scan done, and and as you see here, you can see there is no uptake in the neck area. You can see the chin marker and the suprasternal notch marker, and there was no functioning thyroid tissue either in the thyroid bed or in any ectopic situation. So this was the child with thyroid agenesis or athyrosis, and we commenced on L-thyroxine, the appropriate dose. The initial thyroxine dose is 10 to 15 micrograms per kg per day. When the free T4 is very low, then you must think of the higher dose range, that is like 10 to 15, or if it is those with mild to moderate hypothyroidism, you can start with 10 micrograms per kg per day. So this baby was followed up regularly, and this follow-up regularly is very important because we have to readjust the L-thyroxine doses as required. You know that infancy is a time of rapid growth and development. So there is every 3 months thyroid function test and physical assessment, clinical judgment, all should be done together so that we have we can adjust the thyroxine doses. And we also confirmed this athyrosis by ultrasonography. So what I want to remind you all here is that, you know, at birth, there is a fall in ambient temperature and there is a surge in TSH, a physiological surge in TSH during birth. So cord blood is probably not the ideal thing, but when you look at cord blood, we take 25 as a cutoff. The normal cord blood usually is 10 to 20 micro international units per ml. And this huge surge occurs immediately after birth, and then it starts declining in the 24 to 48 hours. And you can see corresponding to the high TSH, there is a high T4 and free T4 also, and the high free T4 peaks on day 2. After 72 hours, it returns to normal. But as shown here, you can see that it is not returning to adult values, but a value of about 9.1 to 1 micro international units per ml is normal for a neonate. So we have to use age-appropriate values for interpreting the thyroid functions in a newborn. So when we confirm a diagnosis with elevated TSH and low free T4, sometimes we have ambiguous results, and then we may have to repeat these thyroid function tests, and looking for a rising trend of TSH will be helpful to make a decision. So if we do a technetium-99 thyroid nuclear scan and confirm etiology, like suppose you get ectopy, then you know that you are dealing definitely with a congenital hypothyroidism. So that way, the technetium-99 thyroid nuclear scan is quite useful in confirming a diagnosis, because sometimes you get an etiological diagnosis. Rarely we use I-131 scan when we want to do chloride discharge test, especially if there is a big, large thyroid. And technetium-99 scan alone may not be enough. You have to do a thyroid ultrasound scan to confirm agenesis of the thyroid. We'll come to that in the next case. So if we look at this, the causes of congenital hypothyroidism are many. Broadly, they are divided into thyroid dysgenesis, dysharmonogenesis, or transient causes, as we said earlier. And you can see that ultrasound, nuclear scan, and thyroglobulin levels may be helpful for us to make a diagnosis of true agenesis, ectopia, hypoplasia, or hemiagenesis, depending on the findings that you get on the scan and ultrasound. There is a condition called apparent athyrosis, of which we will just come to it. And here, there will be no uptake on the nuclear scan. But if you do an ultrasound, you will see that thyroid tissue is seen and there is detectable thyroglobulin levels. So this can be transient, or sometimes rarely can be permanent. So we should be aware of this apparent athyrosis on a technetium-99 or a radionuclear scan. So there are some thyroid congenital hypothyroidism dysgenesis groups where it is associated with other syndromic associations, especially when it is involving the transcription factors involved in the thyroid development. Like NKX 2.1 is actually the thyroid transcription factor 1, which is early known as 1, and it is also expressed in the brain and in the respiratory system. So depending on where these factors are expressed, you may have some associations along with the congenital hypothyroidism dysgenesis group. And if you look at dysharmonogenesis, as I said before, each step in the thyroid hormone synthesis pathway can be affected. Usually you get an enlarged gland. And again, if it is a sodium iodide symporter defect, the very first step where the uptake of iodine is deficient or uptake of iodine is obstructed, then again in the nuclear scan you will see as an agenesis or an athyrosis. But when you do an ultrasound, you can see an enlarged gland. So this is so I'm coming to the point of transient congenital hypothyroidism. So transient congenital hypothyroidism also can happen where actually the congenital hypothyroidism may be there for a few months and then may disappear. Can happen both with acute iodine excess or chronic iodine deficiency. In both sides, if chronic iodine deficiency, in the nuclear scan you get a very avid uptake, but if it's an acute iodine excess, there will be no uptake in the nuclear scan. So technetium-99 scan is a good, along coupled with an ultrasound of the thyroid, may be very helpful in making an etiological diagnosis. Maternal TSH receptor blocking antibodies can be present, especially with Graves' mothers. And in those cases, sometimes even the fetal thyroid development may be affected. You may get a hypoplastic gland, and on the nuclear scan, you have very low uptake. TSH receptor activating or activating mutations may also be present, or TSH receptor blocking mutation may also be present. This is another condition for transient congenital hypothyroidism. So sometimes you cannot make a full diagnosis in the newborn period time. In those cases, we'll have to have a re-evaluation. All preterm babies and sick neonates have to have a re-evaluation within 2 to 4 weeks, because there may be multiple reasons for that. We'll come to that. And re-evaluation is also necessary when there is an apparent athyrosis or there is mild dysharmonogenesis versus iodine deficiency. We look at re-evaluation of this status. So the learning points from this case is actually the ideal time for screening is either you should do cord blood or please do after 48 hours only. Do not screen during the first 24 hours. And screening is not the diagnosis. You need to repeat the blood test with free T4 and ideally some imaging to confirm hypothyroidism before we commit them to lifelong treatment and you should use age-appropriate values for interpreting TSH and free T4 results in the newborn or even in a child. So the maternal history also becomes very important. Maternal thyroid illnesses which can cause hypothyroid effects on the offspring is, one is, as I said before, maternal blocking antibodies can cross, but the usual antithyroid antibodies, IgG or the TPO antibodies, cross the placenta but usually do not cause any fetal or neonatal hypothyroidism. Maternal hypothyroidism, Graves' disease, is where you can have a lot of effects on the fetus, and a maternal TSH receptor blocking antibody causes transient neonatal hypothyroidism. Mothers on antithyroid drugs like PTU or carbimazole can cause transient hypothyroidism in the baby. So this also has to be carefully followed up. So we'll take you to the second case. The 39-weeker term baby, 2.8 kg, well, had a core TSH of 995. So this test was repeated on day 5. And again, you can see that the TSH is high at 150. The free T4 is very low. The total T4 is very low. And what would be your interpretation? Of course, this is a primary hypothyroidism. But what happened here is there was a normal gland on ultrasound, though the technetium 99 scan had shown a total agenesis. So here you see this is a normal gland on ultrasound, and it can happen either following iodide or even thyroxine exposure, or as said before, a sodium iodide sympota mutation or an inactivating mutation of a TSH receptor. I'm just putting this slide up again so that we have to be very aware about this apparent atheriosis. It occurs quite frequently, and we need to be aware of that. So another case 3, we'll go to the next case. This is a term 3.5 kg neonate. He was operated for diurnal atresia on day 2. He recovered very well, and by day 5 he was started on enteral feeding. Though the screening TSH was normal, jaundice was noted on day 5, and then the thyroid functions was repeated. And here you can see the TSH is 45, the T4 is quite low, 1.5, and the free T4 is also low. What do you think this primary hypothyroidism is due to? So this transient hypothyroidism which occurred in this child was likely due to excessive iodine exposure during the surgery for diurnal atresia, and this is called the Wool-Chaikoff effect. And this is an autoregulatory mechanism to prevent excess trapping of iodide because of the in the baby, but results in hypothyroidism, and is very pronounced in immature newborns. So we have to be aware of the history where these babies are exposed to iodine in antiseptic baths or during procedures or vaginal betadine treatment of breastfeeding mothers. Iodine exposure is something that we should work about. So the learning point here is etiological diagnosis is essential. It's good to confirm permanency when we want to plan long-term treatment. Replacement therapy should be commenced ideally within the first week if possible, or within the first 2 weeks with appropriate doses of L-thyroxine. And we need regular follow-up every 3 monthly with dose modifications. That's crucial for successful management. If you have a doubtful case and the diagnosis was not certain, you should reassess them at 2.5 to 3 years after discontinuing replacement therapy for a minimum of 6 to 8 weeks to look for permanency or whether it was a transient congenital hypothyroidism. Elevated TSH in the newborn period may not always be hypothyroidism, so we have to be reassessing whenever required. Keep in mind Down syndrome, pseudohypoparathyroidism, inactivating mutations of TSH receptor hormones, and so we have to be careful when we assess this. Do we treat this asymptomatic TSH elevation or not? There are different schools of thought. Some people think that if it's above 10, we have to treat and then reassess at 3 years. But if you can closely follow up, you can actually give a trial every 2 weeks, and you can check every 2 weeks and see for the trend of what the TSH is doing and decide whether to treat or not. Most important is looking at the growth and development, and biochemical monitoring is also very important, because some of these patients may go into overt hypothyroidism, or sometimes you may have a iatrogenic T4 excess also. So case 4 was an 80-day-old male infant, was referred here for inadequately controlled congenital hypothyroidism. He was diagnosed outside he was born with a weight of 3.2 kgs, and he was commenced on thyroxine 37.5 micrograms daily. There was no remarkable family history, no history of any maternal medications. He was a healthy baby, and thyroid was not enlarged. So this is the serial test that was done from outside after they commenced on day 20. Day 20, they saw a TSH of 7, the T4 of 3.5, and an FT4 of 1.7. And as you can see, based on these values, treatment was started. But on day 50, the TSH is suppressed, 64, 78, the TSH is suppressed, but the doctor who was treating outside was probably looking at the T4 and was very concerned that the T4 was still low. So he kept the child on thyroxine and then referred later. But if you look carefully at this, you can see that with thyroxine treatment, 37.5 micrograms, the TSH got suppressed and the free T4 has risen to a hyperthyroid stage. So though this LT4 doses were okay, you can see that the TSH suppressed, and what would be the diagnosis in this infant? This is a TBG deficiency, thyroid binding globulin deficiency, where the total T4 can remain low, but the free T4 is normal, and you can see that the high free T4 has suppressed the TSH. And ultrasound had demonstrated a normal this thing. So there is a condition called complete TBG deficiency as described, and the key points are a no metabolic effect. It doesn't need treatment, and it is important to be aware of this. Don't go by the total T4 alone. Please look at the free T4 and also at the TSH when treating, because iatrogenic hyperthyroidism also do have some side effects. If you overtreat with thyroxine, there are short-term risk and long-term risk. Short-term risk are tachycardia, nervousness, disturbed sleep pattern. But the long-term risk is what is they worry. They can have bone age advancement, learning difficulties, hyperactive behavior, premature cranial synostosis, and sometimes even osteoporosis. So we should be very careful that whenever we treat with any hormone, we should not overtreat them. Our experience is we have over 21 years of newborn thyroid screening. I have to mention that this was started by Dr. Raghupati in 2001, Professor Raghupati, when he was here. He started with a cord blood screening program. All inborn people, all inborn babies, about 900 grams have been screened. Close to 2 lakhs have been screened. And we have an hospital-based incidence of 1 in 1,085. And this is our figures. We have a recall rate. If you do a cord blood sample, the recall rate will be a little higher. And resampling rate, we have about 178 babies who have been confirmed. And so we have a transient congenital hyperthyroid percentage similar to that report from Western countries. So ideally, I think we should do a 3 to 5 day sampling and include the screening for IEM, CH, and so. We have persisted with the cord blood TSH because we have been able to collect all the babies who are born in our hospital so far. As yet, because there is no screening program or a health system where they can be registered and called back at a 3 to 5 day interval. So with this, I will end my talk, and my acknowledgements, especially to Dr. Raghupati, Professor Raghupati, who was instrumental in starting this newborn screening program for congenital hyperthyroidism in Vellore, and the pediatric endocrinology nurses and the Department of Neonatology, and my colleague, Dr. Sarah Mathai. Thank you so much for your patient listening.
Sir, MR sir, unmute sir. So unmute. Sir, MR sir, unmute.
Sir, we are unable to hear you.
Sir, unmute பண்ணுங்க sir.
Yeah, okay, now yeah, I got. There has been some technical problem with my computer. Dr. Akhila, you please, whatever questions that are there in the chat box, you may kindly read them out, or I would like you to proceed with your speech. And one question that I would like to ask Dr. Anna is it mandatory that every child where the pediatrician diagnoses congenital hyperthyroidism, let us say in the first few days or weeks of life, should undergo these imaging studies? And is also mandatory they should be referred to pediatric endocrinologists?
That's a difficult question. If you ask me about the thyroid scan, if you have a etiological diagnosis, it's very good for counseling. Like if I have a lingual thyroid, it may present just as a subclinical hypothyroidism. It may present with a slightly high TSH but close to normal T4, free T4. But if I know it is a sublingual or an ectopic thyroid, I can counsel the parents that this is going to be a permanent hypothyroidism. So it gives you an edge over the diagnosis. And when you are counseling, a good diagnosis is something which will really help you in the counseling because they have to be regular, compliant, they have to regularly come. The dosing of L-thyroxine almost changes every 6 months or every 3 months in the first year. So that's very important that the pediatrician is capable of following it. It should not be a problem, but he may try and get an opinion from an endocrinologist who is close by.
Oh, thank you very much. Dr. Ahila, yeah.
It's two questions, madam. One is, how does ectopic thyroid occurs and what is the treatment?
See, ectopic thyroid occurs because if the thyroid gland, as I said, the developmental phase, it starts from the sublingual area and then it has to migrate down. So if there's anything which happens during that migration, just like an undescended testis, the thyroid will get stuck in an ectopic position. So when it is in an ectopic position, it's a dysgenetic gland. It's not a fully mature gland. So it will fail. It will not be a normal gland which will produce thyroxine. The treatment is thyroxine replacement.
So
thank you.
Thank you very much, Dr. Annie, for giving us a clear exposition, especially with respect to the etiology and the need for a frequent, not only the clinical but also biochemical follow-up. And you also mentioned about the risk of over-treating, excess thyroxine, what it could do.
Exactly.
So thank you very much for your, nice exposition on this commonly encountered problem. Thank you. Dr. Ahila, please proceed. There is some technical problem with my, computer, with my, Zoom.
Thank you, sir. Thank you so much, Anna. That was an absolutely brilliant session. Thank you very much. As always, a very, very interesting session. So I will move on to my topic of management of diabetic ketoacidosis in resource-limited settings. So my topic is focusing on usage of insulin, even in small places. If you have a diabetic ketoacidosis, you're anxious, you're trying to push them on to a bigger center where all the facilities are available. I just want to bring it down to the level of a primary pediatrician. This is an emergency which they can manage in their own small hospital setup. You don't need too many investigations. It may help you, but it is not going to keep you away from treatment. So early recognition is the base for treatment of diabetic ketoacidosis. If you suspect any child to have diabetes, that child should be admitted in the hospital stat immediately. Whether the child is stable, sick, it does not matter. I see any number of patients being asked to wait and have a OGTT the next day to confirm diagnosis. Please don't do it. Any blood sugar more than 200, that patient has to go to the hospital. There is less than 5% chance of that being a type 2 diabetes. The child can dip into diabetic ketoacidosis by the time you confirm a diagnosis. And instead of a stable child, you're going to treat a very, very sick child and face complications. If you diagnose diabetes, if you check one blood sugar more than 200, that patient has to go into the hospital stat immediately. I think that's the most important point any primary pediatrician can take from this lecture. The next point, more than all investigations and everything else, it is clinical judgment that is paramount in treatment of diabetic ketoacidosis. You don't need high funda equipment. All that you need is an ordinary IV fluid stand, IV fluid, your fingers to palpate the pulse, and all the peripheral pulses. Look at the dorsalis pedis, the posterior tibial, count the pulse rate, count the respiratory rate, look at the blood pressure, look at the respiratory rate. These are the most important things. The pulse rate, the pulse volume, the capillary refill time, the blood pressure, and the respiratory rate. These are important rather than any other investigation. So clinically, I think everyone knows this. The child could have dehydration, tachycardia. You could mistake it for an asthma. But nowadays, I'm not seeing pediatricians missing diagnosis. More of GPs missing diagnosis. because all pediatricians make it a point to check blood sugars now. I don't see diabetes being missed by pediatricians now. And the most important biochemical point is blood glucose more than 200 milligram per dl. That's it. If you cannot do urinary ketones, you don't do blood ketones, don't worry about it. You cannot do electrolytes, don't bother. You have a blood sugar of more than 200, look at the clinical status. Is the child stable or unstable? So how will you assess dehydration? So in children under the age of 5 years, the clinical signs of dehydration include a prolonged capillary refill time, loss of skin turgor, and an abnormal respiratory rate, slightly more than the rate for that age. If the child has impalpable or weak peripheral pulses or oliguria or hypotension, then it is more than 10% dehydration. Anything between both of these is 5 to 10% dehydration. What are the goals of therapy? All of these are based on the International Society of Pediatric and Adolescent Diabetes, ISPAD guidelines 2018. It is available freely for anyone to access. This is what we based our therapy on. We used it and then we modified it by frequent audit to see how we could improve our therapy. Correction of dehydration, fluids is the most important point you have to focus on. Second comes acidosis. Third is reversing acidosis. Reverse osmolarity. Hyperosmolarity is present because the patient has lost more fluid than they could take in. So this child is hyperosmolar. Don't rush into correcting it fast. So the basic dictum is look at the fluids and correct the fluids. That is more important, and the correction of blood sugars comes far down on the list. Monitor for complications and treat precipitating cause. So fluids are the most important point, and clinical judgment. These are the two important tools in management of diabetic ketoacidosis. Around the world, the diabetic ketoacidosis patients are admitted into an ICU or a high dependency unit, HTU. IV fluids used are normal saline or ringer lactate. They do frequent blood gases. They do a Glasgow coma scale for assessment of neurology and initiation of ventilation. They restrict fluid when there is an alteration in consciousness, and IV insulin is used for treatment of moderate and severe diabetic ketoacidosis. These are charts I think everybody would be familiar with. Look at that first point, shock. That is reduced peripheral pulses and reduced consciousness. And I see a lot of people having a bias during assessment of consciousness. Glasgow coma scale invariably goes at less than 8 or 9 whenever people assess and they think this child has to be ventilated. So I actually don't depend on Glasgow coma scale at all. I depend on the mother's voice. If the mother calls the child and the child even has a flicker of eye contraction, I'm actually against this child being ventilated. Only if the child has an unstable airway or if the child is on the verge of a respiratory arrest, this child has to be ventilated. Otherwise, please hold on to your ventilation parameters. You can cause more harm than help. So please look at your clinical status. Glasgow coma scale is something I'm not at all happy in diabetic ketoacidosis. You have to remember, Glasgow coma scale was primarily designed to evaluate patients with trauma. So that has been applied to all other clinical scenarios. I think it has its own limitations in certain scenarios. So in protocol at GKNM over the last, I think now it's almost 2014. So 7 years now, we have stopped looking at all those parameters which we were earlier doing. And in Masonic also, over the last 2-3 years, we've again shifted to the same protocol. The patients are admitted in GKNM, it is in the general ward. Minimal invasive management. Concentration is on slow and judicious correction of fluid status. Mom's call is more important than Glasgow coma scale. No tubes unless it is absolutely necessary. So I think all of us know the Glasgow coma scale. I think all of us also know about your anion gap and how to calculate for corrected sodium and the effective osmolality. So that is dependent on sodium and plasma glucose. So when you have more and more glucose and with less of fluid, your plasma becomes, sodium becomes more concentrated. So the osmolarity is really high in severe DKA. So as soon as the patient arrives, pulse assessment, which all of us keep on redoing, pulse and BP will be important in defining whether this child even in a sick child, to see whether it has compensated or uncompensated shock, to assess the circulatory status. If the child has tachycardia and the blood pressure is on the higher side, that is compensated shock. If the child has started to go into bradycardia, or if the child has started to go into hypotension, then it is uncompensated shock. So this is the most important point from the pulses and the blood pressure that you're going to get. Level of consciousness, again, as I already mentioned, nothing. Assess the severity of dehydration from the clinical features. So as soon as the patient arrives, oxygen is given only in shock or severe circulatory impairment. Immediate intubation and ventilation in arrest or near arrest scenarios are unstable airway. Have 2 IV lines, measure blood glucose and blood ketones. We are using a meter called Optium Neo H, where you can measure blood sugar and blood ketones. The ketone strip will be different, the blood glucose strip will be different. It is very cheap, not like sending to a lab, and you can immediately see the blood ketones. If it is more than 3 millimoles, then it means the child is in ketosis. Urinary ketones, if you cannot afford or if you don't have a facility for blood ketones. But remember, the urinary ketones are reflecting something that's happened a few minutes or a few hours ago. But in children who are sick, they are completely pouring out urine. So it actually may reflect the status of blood ketones. But it is acetone that is measured in urine, and the maximum ketones in the blood is beta hydroxybutyrate. Measure the weight if you can, or you can assess it by your chart. Blood sample for investigation is taken, and antibiotics only if the child has fever or has a source of infection. No antibiotics otherwise. Don't depend on your counts to start antibiotics. The counts will be high because it's an acute phase reactant. Investigation, blood glucose and ketones. Venous pH if you have a VBG, or along with, you can also look at the PCO2, or you can do just serum electrolytes. Creatinine is extremely important, counts, and HbA1c. So what are the monitoring parameters? Hourly pulse rate, respiration, blood pressure. Cardiac monitoring if you can. You can just use your fingers to feel the pulse, look at the capillary refill time, look at the dorsalis pedis and the posterior tibial. Hourly examination for early signs of cerebral edema. When the child comes and is very sick with acidosis, there is already a damage to the brain, and that is why there is an alteration in the consciousness. That is some amount of cytotoxic edema. Don't restrict your fluids because the child's consciousness is not good. You need huge amount of fluid to correct the hyperosmolarity, but gradually. So fluid restriction has to come if there is a new change in the neurological status. In a child who did not have a neurological abnormality, if there is constriction of pupil or unequal pupils, a new neurological sign like a sixth nerve palsy or something, then you take it as an onset of new cerebral edema and you will restrict fluids. Until then, continue with your fluids. An input-output chart is extremely useful. I don't like putting in a urinary catheter. Most of the children have vaginal candidiasis or candida in the glands, and you're driving in a superficial infection into the body using a catheter. The children will pour urine in diabetes, and you can just weigh the diapers and look at the amount of output rather than putting in a tube. If the child has retention of urine, or the child is, you're going to ventilate a child, you're going to paralyze, and in those scenarios, or if there is anuria or oliguria, please put in a tube. Otherwise, please be extremely wary of using urinary catheters. Fourth, hourly electrolytes, we do it only twice, and a third time if it is absolutely essential. Intubation is avoided because it can cause a sudden increase in PCO2 and can worsen cerebral edema. We don't like central venous catheters. We start an external jugular if you don't get a peripheral line, but otherwise we go for the peripheral lines. And then once the child is stable, we take off our central lines. High risk of thrombosis and removed as soon as the clinical condition permits. Insulin through the central line, it could be diluted. You may not get the expected effect if you're using intravenous insulin. We've already talked about the catheterization. I think this fluid chart is already there on the ISPAD. That is the holiday cigar formula for children up to the weight of 10 kgs is 100 ml per kg per day. This is the maintenance requirement. So if you're going to do it for 24 hours for a 10 kg child, it is 10 kg, so 100 ml per kg per day, so that's 1000 ml. If it is for 48 hours, then the maintenance becomes 2000 ml. So that is the maintenance requirement. If it is for 72 hours, then it is 1000 plus 1000 plus 1000 for 3 days. Severe dehydration with compensated shock, no bolus. If at all you want to give a bolus, the pulse volume is not good. And even after regular fluid for 1 hour, you feel that the pulse volume is not picking up, you can give 10 ml per kg of normal saline bolus. Never pushing in fluids unless it's a decompensated shock and the child is crashing. Calculation of fluid for 10% dehydration plus the maintenance, and it is infused at the calculated rate. Fluids are calculated for 48 hours in children older than 5 years and 72 hours in children under the age of 5 years. This is what we are doing so that we don't push in too much fluid too fast. So I have an example here. If you have 7% dehydration, then it is 70 ml in a 20 kg child. 70 ml into 20, so that is 1400 ml. So this is for the dehydration correction. Maintenance fluid for 48 hours. This is a slightly older child. So you're going to do it for 48 hours. So 1000 plus 500. So 1500 for 24 hours, and for 2 days it becomes 3000. So a total of 4400 ml over a period of 48 hours. Your infusion rate is 92 ml per hour. So the same way, if you assume 10% dehydration, then it becomes 100 ml into 20. So your dehydration correction is once. Your maintenance correction depends on the number of hours you're going to take to correct. So these are, there is no bolus except in uncompensated shock. 10 ml per kg of normal saline quick bolus in uncompensated shock. In compensated shock, if the fluid is not picking up, if the pulses are not picking up and the ketones are not clearing well, then you might give a bolus over 1 hour. Reassessment, bolus is repeated if necessary. After 3 boluses, you cannot, only crystalloids are to be used for the first 2, and occasionally in certain scenarios, you might use a 3rd bolus. Otherwise, you'll have to shift to other parts of management. The fluid replacement is to expand volume and restore circulation. Replace fluids over 48 hours, dehydration correction plus maintenance. Isotonic fluid for the first 4 to 6 hours. We use only normal saline. We are not sticking to anything else because as such, it is a hyperosmolar state. Any fluid you use may be relatively hypoosmolar. And we use half normal saline or normal saline based on sodium. If the sodium is more than 140, we use half normal saline. If the sodium is, if the sodium is less than 140, we use normal saline. If the sodium is more than 140, we use half normal saline. We add potassium based on the electrolyte reports which we get at 4 hours. If the potassium is more than 4.5, we don't add potassium. 4 to 4.5, we add 1 cc KCl per 100 ml. That is 20 milliequivalents per liter. If the potassium is less than 4, we add 2 cc KCl per 100 ml. That is 40 milliequivalents per liter. For children under the age of 5 years, our target is 300 milligram. If the child's blood sugar drops to less than 300, we make it 5% dextrose containing normal saline or half normal saline. If it is a child who's older than 5 years, the target is 250. So the deficit replacement after 4 to 6 hours is usually continued with half normal saline with potassium. Start oral fluids as soon as the child asks for. Don't look at the ketosis. Don't look at the acidosis. The child will not ask for fluid if the ketones are high because there will be a sense of nausea. They don't like drink. Or if the child asks for food, that means there is clinical improvement. You can give something to eat. It may be simple things like a sip of water first and then food. You don't have to have complicated investigations to give food. Hyperchloremia may mask the resolution of acidosis. That is why after the first 4 hours of fluid, sometimes your bicarbonate may be lower than the initial one. That is because of the chloride effect. Insulin is started 1 to 2 hours after starting fluid replacement. The sicker the child, later we start the insulin. If the pH is 7 and more, we usually start insulin at 1 hour. If the pH is less than 7, we start our first dose of insulin 2 hours after fluid. It can be subcutaneous, intravenous, or intramuscular. There is no bolus because it can increase risk of cerebral edema and worsen hypokalemia. So first dose, we use subcutaneous insulin. The first dose is regular insulin because you always worry about absorption from the subcutaneous tissue in a child with shock. You already know that we have already restored the circulation before we started insulin. So we are using regular insulin, 0.05 to 0.1 unit per kg. The first dose is a lower dose. So we use 0.05, and the younger the child, lower the dose again. If the pH is more than 7 after 1 hour, if the pH is less than 7 after 2 hours of fluid. And then for every 3 hours after that, we use 0.1 unit per kilogram. In peripubertal children, during puberty, they are insulin resistant. Sometimes we go as high as 0.15 unit per kg every 3 hours. So I already mentioned about the target that you are going to look at. If the glucose concentration drops, you first step up the glucose concentration to 6.75% and then 7.5%, and then only you start reducing the insulin. You have to keep continuing the insulin and increase the glucose concentration rather than reducing the dose of insulin. So I already mentioned about all of these points earlier. Okay, bicarbonate. We almost never use bicarbonate. It can cause paradoxical CNS acidosis. Rapid correction of acidosis with bicarbonate can cause hypokalemia. You also worry about your pontine myelinolysis. We very, very rarely, I mentioned because Professor Ramasamy sir asked me the other day on the scenarios where you use bicarbonate. After the initial stabilization, persistence of acidosis is seen in certain scenario, like prolonged sepsis or renal failure. In those conditions, I add bicarbonate, but not in the immediate resuscitation period. It is later. In life-threatening hyperkalemia, that's one scenario where you can use bicarbonate. Transitioning to oral fluid, as I mentioned, if the child asks for it, you give it. When will you change to subcutaneous insulin? Once the child starts eating, then you can shift to subcutaneous insulin. We don't actually wait for biochemical parameters. We look at the clinical condition of the child. So we looked at our data over a 2-year period. I've just sent off this manuscript to Indian Pediatrics. We had number of DK episodes, 29 in the subcutaneous group and 22 in the IV group. The range of pH is almost similar between both, 6.83 to 6.82. The dose of insulin used in both the groups per day is almost similar, but look at the time to recovery. We were really surprised. We were actually doing this to cut costs, to help poor families manage diabetic ketoacidosis in our hospital. But what we realized, another benefit was the mother gets to stay, the family is nearby, the child is less anxious. So we were treating in the general ward. But when we looked at our data, we saw that the time to recovery in patients on subcutaneous insulin, the mean is 10 hours, whereas it is 35 hours in children on IV insulin. And the cost of therapy is 14,000 plus or minus 6,000 rupees for subcutaneous group. It is almost 4 times more in patients who are admitted to the ICU for therapy. So this is our data on how the recovery happened for intravenous insulin and the subcutaneous insulin. So to help more people get affordable care, initial education helps in the long-term outcome. We found that there is a reduction in time to improvement on subcutaneous insulin. I will not go into cerebral edema because I think we have very little time, and we've got 4 short case presentations from our postgraduates. So clinical examination with blood sugar, electrolytes are the basic minimum investigations that are necessary. Hourly pulse rate, respiratory rate, and blood pressure can guide therapy along with hourly blood sugar. Adequate fluid resuscitation is imperative before insulin therapy. Insulin is initiated after fluids for an hour or 2 based on the pH or the clinical condition. A repeat electrolytes 4 to 6 hours later helps in taking decisions on what fluid to continue and whether to add potassium. And any potassium concentration I have added beyond 40 milliequivalents. Whenever I've gone beyond 40 milliequivalents, I've had children complaining of palpitations. So we never go beyond 40 milliequivalents per liter. If at all the potassium is low after that, we add oral potassium. Blood sugar target during diabetic ketotherapy, I think I've already mentioned all of this. The only other point I would say is look at the insulin. Whether it's a 40 unit insulin and the medication also is 40 units per ml. I think that's all I would want to have. Thank you very much. If my manuscript gets published, then I can probably, you have a flow chart on that, all of this put into one single flow chart, which was very difficult to put on the slide, so I could not do it today. And I hope it gets published, and then probably you can all see that. Thank you very much.
Yeah.
Ahila, it's absolutely wonderful. I'm very glad that you have made it a simple, inexpensive, and it could be practiced by the pediatricians. I think this is really the need of the hour, unlike following that intravenous insulin and ICU care, etc., etc. So I cannot agree more on all the points that you mentioned. Indeed, before all the endocrinologists came on the scene, this is what I had done after many of my diabetic ketoacidosis. I never lost any child diabetic ketosis, nor did I have any cerebral edema. So I think, I really cannot agree more, as I mentioned earlier. So any questions, I think you please, attend to those questions.
Sir, can I take the questions after the students present, because they are also waiting for a long time to present, and there are some short case presentations.
Okay.
Yeah, and my email ID is ayavuahila@gmail.com, which I will type on the chat box. You can all send your questions to me, and I would definitely manage to answer them. If I can, I will also answer it after the students present, because they've been waiting for some time. And may I request, thank you so much, sir, for the chairing of the session. And we would be happy and appreciate if you could continue being on the session for the students to present. I would also like to welcome Dr. Anna Simon, Dr. Shaila Bhattacharya, Raghupati sir. Sir is also here. Yeah, Raghupati sir and Dr. Lakshmi Velmurugan for the students to present their case. We have 4 short presentations. First, I would like to welcome, I think it is Gautam. Yeah, Gautam, can you start your screen sharing and present the case, the first case?
Yes,
yeah. So these are all going to be 5 minutes of presentation, 5 minutes of expert comments by the faculty, and then 5 minutes for questions.
Good evening, everyone. I'm here to do a short case about a toddler who is 1 year 9 month old girl brought to us with the complaints of bowing of her legs for the past 6 months. She also had irritable cry before the 6 months. On evaluation, she was found to have a right clavicular fracture, and she was treated with a sling. She did not have any history of fall or trauma during that time. And there was no history of vigorous or weight-bearing activities, no history suggestive of trauma or injury, no history of fever, bone pain, or chills, or any chronic drug intake, no previous hospitalizations or any daycare procedures. She was second born to non-consanguineous parents. Mother did not have any antenatal issues, and she was delivered in an institution. No history of any birth injuries. She was exclusively breastfed till 6 months of age, and she was weaned after that. Vitamin D supplements were not given to her by her parents, and at present she was taking normal diet along with the diluted cow's milk, and as per history she was being overfed. This toddler is well immunized up to date and developmentally normal. She has an elder sibling of 6 years of age, and there was no other significant history in the family. And examination, she was alert, active, and cooperative. Her weight was 12.5 kg, which was between 75th to 97th percentile, and the height was 82.5, which was within the centiles. And her vital signs were normal. Systemic examination, her musculoskeletal examination showed widening of both wrists, genu varum, double malleoli, and a beading of costochondral junctions, along with the lumbar lordosis. Other system examination were normal. Her blood investigations, blood counts, and urine analysis were normal. Urea, creatinine, and bicarbonate were within normal limits. She had elevated parathermone alkaline phosphatase and a low phosphate and vitamin D. These were the X-ray pictures of her wrist and knee, which shows cupping and fraying of the wrist joints, along with the sharp metacarpal ends. And the diagnosis of nutritional rickets were made. And she was treated with vitamin D and calcium supplements. And the vitamin D dosing was 1.5 lakh international unit, single dose, along with the calcium supplements. And following which she was followed up regularly. She showed a very gradual improvement. and her niece and lordosis improved well, and a maintenance dose of vitamin D was continued. This was her parameters, and the initial blood investigation showed like elevated parathormone, elevated alkaline phosphatase with a low vitamin D and phosphate, and her calcium was within normal, which is because her body is compensating. And coming to rickets, rickets is a disease of a growing bone before the fusion of epiphysis. It is the most common condition seen in day-to-day practices. Parents often fail to notice the initial signs and come to us when they have visible changes or fractures. And early complaints of rickets may include irritable cry, bone pain, and tiredness. And in most of the scenarios, history gives significant clues. For example, like failure to give vitamin D supplements in infancy, prolonged breastfeeding without weaning, no outdoor activities, dark skin children, low calcium and vitamin D diet with a low socioeconomic status, and a special diet which excludes dairy products. These may point out towards nutritional. Other signs of vitamin D deficiencies may sign towards malabsorption. If the child has frothy urine, hematuria, polyuria, or acidosis, that may point towards a chronic kidney disease. Presence of similar history in the family could be related to genetic conditions. So vitamin D dosing, this is a consensual international guidelines of prevention and management of nutritional rickets, and this is the dosing which we administer to the children. For toddlers, we till 12 years of age, we administer single dose of vitamin D of 1.5 lakhs, and more than 12 years, we administer 3 lakh, and the maintenance dose as mentioned here. And this is IAP guidelines for rickets, where both calcium and vitamin D doses have been mentioned. And the vitamin D should always be supplemented along with the calcium. And in hypocalcemia, we should first see if the child is having either symptomatic hypocalcemia or asymptomatic hypocalcemia. If the child is asymptomatic and is able to take orally, oral supplements will be fine. And if the child has symptoms, or if it is child is unable to take it orally, or if it is acute hypocalcemia following any surgery, then intravenous calcium is preferred over oral. And both calcium gluconate and chloride can be used as IV supplements, and gluconate is preferred because it is less likely to cause tissue necrosis, and the dosing is 0.5 ml to 1 ml per kg of 10% calcium gluconate administered over 1 hour under strict cardiac monitoring. And infusion should be carefully monitored for any extravasation too, and it can be prepared along with the dextrose or saline boluses, saline water like saline, because isolated calcium may be irritant to the veins, and it should not be added along with the bicarbonate or phosphate in a single line, which can form in calcium salts. If they are to be administered, then a separate line should be used. Thank you.
Thank you very much, Gautam. You can stop screen sharing. Dr. Raghupati, sir, would you want to make any comments, sir, for the practicing pediatricians?
I think you said it's a common condition, but it's not the most common condition. Most common conditions are respiratory infections. And in pediatric outpatient, we do see quite often. And the major finding or the complaint for which they come is the absence of motor milestones or not developing motor milestones, and that's the common complaint. And so we need to be very careful in examining for vitamin D deficiency rickets. You also mentioned prolonged breastfeeding. I don't think that is a correct one. And in fact, you all know that vitamin D is not present in our diet at all. And also, I've always wondered, some people who are quite well-to-do and provide a balanced diet, still their children develop rickets or vitamin D deficiency rickets. Quite often, the mothers are deficient in vitamin D. And so the child also develops. And it may be lack of exposure to sunlight or whatever. But I don't think we can attribute any dietary cause. But the rest of the comments, I'm not. One more thing on the X-ray, you said cupping and fraying of the wrist joint, which is not correct. Cupping and fraying is seen at the metaphyseal sites. And the most important finding is the widening of the metaphysis and fraying. Those are the specific radiological findings which you should say. You can see that in any metaphysis. It's also there in the phalanges also, not only in the wrist joint. So wrists are the preferred site for radiological examination.
Yeah, we actually had taken the distal end of the tibia because that was even more obvious because the child was standing. He mentioned it as the knee. It was actually well seen at the distal end of the tibia in that X-ray.
The changes do appear in the wrist, which is right side to do. And it's also easy to X-ray.
The only point that I would like to make to what Professor Raghupati has already added, rickets, as a matter of fact, remains unrecognized for many months. As he said, it is the delayed acquisition of motor milestones should, whenever it is there, this rickets should come in the differential diagnosis. An additional point, you mentioned about crying and irritability. By and large, what I have noticed with rickets children, for all practical purposes, a painless disease unless there is a fracture that occurs. So one must actively look for in the examination evidence of a metaphyseal widening or a gastrocanal enlargement. So besides delayed motor milestones and also hypotonia. And I think, one should actively look for it. Of course, the biochemical investigations, X-ray, give you the diagnosis. And secondary hyperparathyroidism is there. And I do not know because my patients, I always treat them with daily dose of 2,000 units of vitamin D instead of giving them one single shot. Because there are some people who say that might produce some hypercalcemia in some individuals. So I have relied, as long as the compliance is assured, I have given them a daily dose of 2,000 units per day, which comes to about 60,000 units per month, along with the calcium. And within 3 months, there should be an improvement. The end of the month, there should be a radiological improvement. By the end of 3 months, there should be a very good improvement. In the absence of improvement, one needs to worry about other conditions giving rise to rickets. I don't know what Professor Raghupati feels.
No, oral treatment in the doses that are given, which is a consensus, a guideline, it doesn't cause any adverse effects of vitamin D toxicity. And so I think that's...
Dr. Raghupati, your voice is low. You have to keep the mic, yeah.
Those guidelines given by the consensus group is quite good and it is given orally. And if you stick to that dose, it does not produce any vitamin D toxicity. That's our experience. And when you see a vitamin D deficient child, sometimes we give once a week for 6 weeks, and then we make it once a month. And it works very conveniently. And daily, as you said, compliance may be a problem. And it's easy to give according to the consensus guidelines.
Thank you very much, sir. Thank you, Raghupati sir and MR sir. Thanks, Gautam, for that presentation. I think we will go on to the next presentation. Dr. Priyadarshini, are you ready? Can you start screen sharing?
Give a clap to PG.
If I
give a clap to the PG who presented.
Gautam, there is a clap for you from Professor Srinivasan, sir. No, I'm actually planning to scold him tomorrow, sir.
Indeed. Yeah, okay, good.
If I may add one more line, Ahila.
Yes, sir. Please, sir.
No, children in the same family, all of them don't develop rickets. It's just one child, and all of them eat the same food and the same kind of activity. Why does one child develop rickets was always my question in my mind. I've asked experts and I've asked all the consensus group experts, and they're not able to answer that question. Finally, they will say the calcium intake may be different.
So can I add a point to that? So some of these children whom I have followed up, because in the same family, I think another child I just saw yesterday, the elder brother is fine, but the younger sister developed rickets. But if you look at her, if you give her STOS therapy, after 3 months, her vitamin D drops like a rock. Every time we try to take her off, she dropped like a rock. So she's on daily replacement. I'm not sure if some of them have an inability to store vitamin D3 in their liver. And that could be the reason for the difference in manifestations amongst children in the same family. So for all these children, I've actually kept them on regular RDA allowance every day to maintain their vitamin D3 levels. Almost like
vitamin D.
Vitamin D3, they are not able to maintain their vitamin D3
every month you should take.
Every month you take, it drops, sir. Only if they take every day that low maintenance dose, they're able to maintain their vitamin D3.
Keep following, and I'm sure you will have Ahila syndrome. Yeah.
There are a few of them like that, but I'm not sure I do.
Yeah, you must collect data, and then you are a meticulous person. So I wish you all the best.
Thank you, sir. Priyadarshini is our post DCH DNB resident, and she's presenting the next case.
Good evening, one and all. I'll be presenting today an interesting cause or case of tetany in this academic session. This is a 14-year-old boy who presented 3 months ago with complaints of recurrent episodes of muscle cramps since 1 year involving muscles of lower limb, each episode lasting for 1 to 2 hours, which was associated with perioral numbness and lightheadedness. The above-mentioned episode was not associated with loss of consciousness. There was no history of tonic-clonic movement, tongue bite, aspiration, involuntary urination or defecation. There was no history of fever, chronic drug intake, or neck irradiation. For the above complaints, he has consulted a local pediatrician and he was started on calcium and vitamin D supplements. He had hospitalization at 1 year of age for febrile seizures. There was no history of surgeries in the past. His paternal uncle is suffering from cerebral palsy and parathyroid adenoma, who got operated at 31 years of age for pathological fracture. In view of recurrence of symptoms, he was referred to GKNM for further management. On arrival, he was conscious, oriented. There was no carpopedal spasm. He was normal looking child, except he is tall built. This is his growth chart showing height above 97th centile and his weight is just above 75th centile. His vitals were age appropriate and his systemic examination was within normal limits. Investigation done in outside hospital showed low vitamin D, low calcium with elevated ALP, suggestive of vitamin D deficiency. USG neck done outside showed bilateral submandibular lesion, possibly ectopic parathyroid. In our hospital stay, investigation done at the time of tetany showed respiratory alkalosis with PCO2 of 24.9 and ionized calcium was low of 3.7 milligram per deciliter. Vitamin D done here was normal and ALP was elevated of 330 units per liter. Ultrasound neck done showed bilateral cervical lymphadenopathy. Parathyroids were normal. He was managed conservatively with calcium supplements. In view of alkalosis, hypocalcemia, and retrospective history of anxiety episode associated with every episode of tetany, he was started on psychogenic hyperventilation syndrome was suspected and he was started on psychiatric counseling and anxiolytics. He was discharged with a diagnosis of recurrent tetany, recovered vitamin D deficiency, and psychogenic hyperventilation syndrome. On follow-up, his lab values all were normal except a mildly elevated ALP, and his symptoms, frequency of episodes has come down. Brief approach to hypocalcemia. A child presenting with hypocalcemia, we should see ionized calcium. Low ionized calcium with low phosphate and high parathyroid hormone, we should suspect vitamin D deficiency, pancreatitis, anti-epileptic drug intake, bisphosphonates, blood transfusions. Low ionized calcium with low parath hormone, we should consider hypoparathyroidism and hypomagnesemia. Low ionized calcium with high or normal phosphate with high parath hormone, we should consider acute renal failure, rhabdomyolysis, and massive tumor lysis, pseudo-hypoparathyroidism. A few points on psychogenic hyperventilation syndrome. We usually see considerable number of children, especially adolescents, who present at odd hours to our ER with tachypnea without any organic cause. In those children, psychogenic hyperventilation should be considered, and an empathetic and psychogenic approach is needed in those. Triggers usually are acute emotional stress and attention-seeking behavior. Mechanism is any anxiety episode or emotional stress resulting in hyperventilation syndrome results in respiratory alkalosis. Alkalosis causes the free functional ionized calcium to bound to albumin, making it unavailable for cell function, resulting in symptomatic hypocalcemia. A differential diagnosis, though this is a distinctive episode, possibilities of central causes like focal seizures, transient ischemic attacks, and most importantly, poisonings like carbon monoxide and salicylate should be considered. Treatment, acute episode, though traditionally we practice rebreathing from a paper bag, it carries its own risk, proving detrimental in acute exacerbation asthma. So advanced techniques of controlled breathing like 7-11 breathing technique can be used, where patient is allowed to inhale for 7 seconds and exhale for 11 seconds, which a ratio of which can be gradually decreased to 412, 420 till the symptoms improve under careful saturation monitoring. Long-term management, the child should be on psychiatric counseling and anti-anxiety drugs depending on the individual presentation.
Thank you.
Take home message, all tetany are not due to organic cause of hypocalcemia, can be psychogenic too. Thank you.
Thank you, sir. Yes, sir, Professor Srinivasan, sir.
Yeah, can I make a comment?
Please, sir.
When she presented this case, I remembered one of my junior MBBS students when I was senior house surgeon in medicine. So he used to have this hyperventilation syndrome and he used to have tetany, typical coach's hand and this thing. And I used to give IV calcium slowly, very slowly monitoring, and he used to immediately improve. So, so this is I remembered about this case. So we had to be very careful about this thing. And of course, later he became all right and he became a professor of medicine. Okay, so that is a different story. Thank you so much.
Thank you, sir. Dr. MR, sir, you want to make any comments, sir?
Yeah, I think, it's, the presentation, has been done fairly clear, well, and very little that I can add because it doesn't seem to be anything organic going on there. Yes. Even though the little bit of, hypovitaminosis D, was noted. And
just a comment.
I have no additional comments.
Okay, we are seeing psychogenic hyperventilation in adolescents quite frequently now, and some disorders which we never thought we will see. I'm also seeing anorexia nervosa not frequently, once in a while at least in Coimbatore now, in girls. So we are seeing psychological disorders in adolescents more frequently, I felt. So we just thought, because this child was extensively investigated and they said ectopic parathyroid, which I've never heard of. I tried to find out if there was any report of ectopic parathyroid. Then finally, we just talked to him and sat and spent some time with him, and then we noted it to be only psychogenic hyperventilation. Yes, sir, please, sir.
Recurrent vomiting also can cause alkalosis. And I've had a patient, especially a newborn, was found to have hypocalcemia. And we used to, in Vellore, we used to give a high concentration of calcium chloride solution prepared in our pharmacy. It had 27% calcium. It's supposed to be given only for 2 days. But if you don't write the order 2 days, it will keep on continuing. And that will cause severe gastritis and vomiting. And we found it very difficult to find out the cause. We have to do some detective work. And after that, when you write calcium chloride solution, you have to write 2 days. So I just wanted to say that's also a possibility. It's not only respiratory alkalosis; it can be metabolic alkalosis also. And as Haila mentioned, psychogenic vomiting seems to be on the rise. I'm also seeing some patients here in Bangalore.
Thank you so much, sirs. Thank you, Priya. That was a good presentation. We just thought we'll present all these simple cases because it will be useful for PGs and practicing pediatricians. Now we have...
what is the age of this thing?
14-year-old boy, sir.
14 years.
14 years, okay.
Next, can I invite Dr. Monish Balaji to present a short case?
Good evening, one and all. Here I'm going to present a case of an infant with poor weight gain. So we had a 2 month, 23 days old girl baby who presented to us with failure to gain weight for the last 1.5 months. On history of poor feeding was present, no history of vomiting or any other complaints. Her antenatal, birth history and developmental history was normal. Family history, she was born to non-consanguineous parents. On clinical examination, on looking at the growth chart, her height and weight were both below the 3rd centiles. On clinical examination, genitals revealed ambiguous genitalia. Here we can see hyperpigmented rugal labioscrotal folds and prominent phallus with no palpable gonads. I just want on ambiguous genitalia, the most important things we have to look at is we have to look at the clear genital anatomy. The second thing is we have to look at the urethral meatus, whether it is present. The third thing is we have to always palpate the labial region to look for any testicular tissue present. The most common mistake we would have taken this as it probably would have been taken as a male child with an hypospadias with an undescended testis is what we would have thought, but this is actually a female child and the labial, there was no gonads palpable. So on clinical examination, the weight was below 3rd centiles and the height was below 3rd centiles. The baby looked emaciated, vitals and systemic examination was normal, and genitals revealed clitoromegaly and posterior labial fusion. On investigating this child, her blood counts was normal. The random blood sugar was 87.48, which was normal. Serum electrolytes, sodium was 143, potassium 4.5, and bicarb was 22, which was also normal. In this baby, we had done a synaptin stimulation test, which revealed elevated 17-hydroxyprogesterone levels. It done at 0 minutes, 30 minutes, and 60 minutes, which was all high. And the dehydroepiandrosterone levels were also high, and cortisol levels were low in this child. The plasma renin activity done in this baby revealed 1.78 nanogram per ml per hour, which is also normal. So here we have, there is some enzyme deficiency causing elevation of precursor steroid 17-hydroxyprogesterone and resulting in deficiency of cortisol. And these precursor steroids have been diverted to the pathway of excess androgen production, resulting in elevated dihydroepiandrosterone levels. In these babies, to always know the sex, it is better to get a karyotyping done. And karyotyping of this baby showed 46 Xs for being a girl child. And we did an ultrasound abdomen for this child, ovaries and uterus were present. So I just want to summarize, it is a 2 months, 28 days old baby presenting to us with failure to thrive and poor weight gain. Clinical examination revealed ambiguous genitalia. Our investigations revealed elevated 17-hydroxyprogesterone levels and elevated dehydroepiandrosterone levels with low cortisol levels and normal plasma renin activity. So this is a case of non-salt losing virilizing CH. So in this baby, we are treated with hydrocortisone at the dose of 15 to 20 milligram per meter square per day in 2 to 3 divided doses. We measure the adequacy of treatment or adequacy of therapy is measured by the normalization of 17A OHP levels. So this was the baby after we had started treatment. You can see the regression of cryptomegaly. The most important thing, that is, we as local pediatricians, when practicing outside, when we receive any CAH baby in a period of stress, if the child is having fever or child is presenting us in severe acute gastroenteritis state, what we have to do is we have to double the glucocorticoid dose. The glucocorticoid dose must be doubled or tripled every 6 hours orally. Suppose the child is getting 1.5 mg TDS, we have to increase it to 1.5 mg every 6 hourly. In an emergency situation, we can tell the parents to give an homemade ORS, which we'll make by preparing a pinch of salt and sugar and water. If the child is presenting to us if the child is having severe vomiting or child is present to us in an unconscious state, it is always better to give an IV hydrocortisone and a dose at least twice or thrice the usual dose can be given. Here in GKNM, we teach the parents how much dose to begin and how to be given. And it is necessary to go to the nearest hospital and dextrose needs to be infused. We should remember that treatment should never be discontinued. As the child grows, the dose of glucocorticoids will be adjusted as per growth and biochemistry. On follow-up, we repeat 17-hydroxyprogesterone levels. That we maintain the 17-hydroxyprogesterone levels in the high normal range or normal levels. Low normal levels are achieved only with excessive glucocorticoid doses. We have to monitor their growth and weight, and we have to maintain linear growth along percentile lines. And we have to look at the genital examination for regression of cryptomegaly. Thank you.
Can I ask you a question, Maunesh?
Please, sir. Please ask him, sir.
Yes, sir.
What is AAA syndrome? You know?
He doesn't know, sir.
Sir, no, sir.
No, I thought of that because today I am seeing a AA syndrome, Ahila-Ayavu syndrome. This patient has shown such improvement with hydrocortisone, which we don't usually see. And this is, as Dr. Professor Srinivasan was saying, this should go down in history as AA syndrome. We have seen so many patients, we treated the same way, but we have not seen such regression of cryptomegaly in a remarkable way. Okay. And I've seen this case before. She has shown us this before. And so that's why I was tempted to say that. You said, is there a urethral opening? You must always see whether there are two openings, not just one. One is a bit of an abnormal situation here. And I also wish you had put ultrasound first rather than karyotype above that. Okay. Straight away, you can make a diagnosis. That's what I used to do. When I see a patient like this, I will take the child straight away to ultrasound. 17 OHP will take time. Okay, karyotype will take longer time. So you can get a diagnosis. If there are no gonads and if the ultrasound shows Mullerian structures, then straight away you can make a diagnosis that this is a virilized female. And so that would be my comments here.
Dr. Ahila, I think the point made by Professor Raghuvati is a very valid one. I think, ultrasound straight away tells you the presence or absence of uterus. In the presence of uterus tells you that's going to be a female. And not only that, but I'm a little surprised this baby with cortisol deficiency remained, so for so many weeks without going into shock. I was a little surprised about that. So much a cortisol deficiency, and only 6 weeks, baby did not go into any acute situation, but only chronically getting wasted.
Now the mineralocorticoids, that was probably though low, not very low, to cause shock. And mineralocorticoids are very, very potent. So even a small amount will prevent them from developing hyponatremia, hyperkalemia, and going into shock. That is the reason. And non-salt losing is a clear entity.
Dr. Professor Raghupati, recently we had a small infant about the same age, also marasmic, and didn't have actually, ambiguous genitalia, but little bit hyperpigmentation over there. But our investigation turned out to be an isolated hereditary cortisol deficiency. And the genetic study confirmed it. Isolated cortisol deficiency without any, additional, excess sex steroids, androgens, like that. So, I mean, these may be presented more or less in a similar manner, but without much of, no hyperpigmentation, not much of a virilization either. But the baby's, blood pressure was low, sugar was low, and then when we did the hormone studies, that the cortisol level was low.
It was a familial glucocorticoid deficiency case.
Yeah,
I
remember that, because that's a very similar presentation, but without this external genitalia becoming liberalized, without hyperpigmentation, or without going into any, as a general pediatrician, I was just thinking, any, cortisol deficiency, and sooner or later may produce hypotension, hyperglycemia, may throw the child into, this is what we see in older children with acute adrenal insufficiency. I'm just wondering, what made this baby remain this relatively stable?
Can I make a comment? Yes, so as Akhila was saying, familial glucocorticoid deficiency, there is type 1 to type 5 based on the genetic defects. We have a series of 4 of them. They are not congenital adrenal hyperplasia for virilization. They have a defect in the cortisol production in a different way. There are 5 types of familial corticoid deficiencies. Some of them with association, some just plain with cortisol deficiency. So you may have been dealt with one of them, Professor Ram.
Okay, thank you. Thank you very much.
In familial glucocorticoid deficiency, the adrenal cortex does not develop at all. So they actually don't produce androgens. So you don't have adrenal androgens, and that is why you don't see virilization in familial glucocorticoid deficiency. That's an entirely different entity from congenital adrenal hyperplasia, sir.
I was mentioning AAA syndrome, which is adrenal insufficiency, alacrima, absence of tears, and achalasia cardia. Okay, these are the 3 things. And they don't present with shock, Professor Ramaswamy. That's because they're mineralocorticoid, they're intact. They don't present with shock. And they present with hyperpigmentation, difficulty in swallowing, and later on, alacrima, we have to always probe into the history and get that finding. And so the absence of shock, I was wanting to tell you, can be delayed. And non-salt losing is very, very common. Actually, there is one deoxycorticosterone. That's a very potent mineralocorticoid. That will be in excess. And beyond 21 hydroxylase deficiency, proximal. And that's why we don't get any shock.
Thank you very much. Thank you. I think, okay, fine. Dr. Akhila, the other, of course, there has been a recent, a little change in the expression of the failure to thrive. And slowly that's being replaced by another expression called growth faltering. Indeed, poor weight gain in the first few weeks or months of life. Much better to call that, because in this particular infant, you would find the length is relatively, much better compared to the weight deficit, much more than the length. So this type of situations in the first few months of life, people now learn to use another expression called growth faltering instead of the failure to thrive, which used to be the collective term. So the growth deficit, the weight deficit much in excess of the length, much better expression would be to call it a growth faltering, and then start looking into exogenous and endogenous causes. And this particular infant had endogenous cause. Okay.
Thank you very much, sir. Thank you, Monish. Can I just request our next presentation by Dr. Divya? Divya?
Yes, ma'am.
Okay. Can you share your slides, please? I was surprised when Dr. Shaila Bhattacharya said and Dr. Lakshmi Velmurugan asked how common is type 2 diabetes. I thought they actually smelled our case even before we started presenting.
Good evening, everyone. Today I'm here to present a case of type 2 diabetes mellitus and autoimmune hypothyroidism. So here we have with us a 10-year, 3 months old female child from Coimbatore who presented to us with complaints of
go ahead, please. Yeah.
Of itching over the genitalia for the past 3 months and increased water intake for the past 3 months. So this girl was apparently normal till 3 months back, after which she started developing itching over her genitalia, which was on and off. She has started drinking excessive water, but does not get aggressive when water is not given immediately. Her urinary frequency has also increased, and she has also developed nocturia. She consumes double the amount of food she was eating last year, and her screen time almost exceeds more than 4 to 5 hours a day. She has a very sedentary lifestyle with almost nil physical activity, and she has lost 3.5 kilograms in the past 3 months. She had no significant illness in the past, and her mother had gestational diabetes mellitus at 8 months of gestation. There was no history of pregnancy-induced hypertension. She was born preterm at 32 weeks by LSES. Her birth weight was 1.75 kg and she had a NICU stay for 7 days. Her developmental history was normal, like she had attained all the age-appropriate milestones in all domains and she has a good scholastic performance. She was born to non-consanguineous parents and she has a strong positive history of type 2 diabetes mellitus in her maternal great-grandmother, maternal grandmother, and her mother, who developed gestational diabetes mellitus in her antenatal period, continued to have diabetes and currently her mother is on insulin. On examination, she looked calm, conscious and oriented. Acanthosis nigricans was present and there was also central adiposity. There was no distress. And coming to the examination of the neck, there was a uniform soft thyromegaly. The borders were not clear-cut and there was no lymphadenopathy. Her Tanner staging was breast was stage 1 and pubic hair stage 1. Her vitals, she had bradycardia with a pulse rate of 62 per minute. Her other vital parameters were normal. Anthropometry, her height was 133 centimeters, which was between the 25th and 50th centile. But her mid-parental height was 145 centimeter, which was like well below the 3rd centile. And her weight was 36 kgs, which was between the 75th and 90th centile. And her BMI for age was between the 23rd and 27th centile, so she was overweight. And her systemic examination was normal, but for the central adiposity, and her CNS showed delayed dependent reflexes. So here we have with us a 10-year-old child with a history of gestational diabetes mellitus in her antenatal period and who was born SGA with a birth weight of 1.75 kg and a preterm at 32 weeks, who continued to have a normal development and started developing symptoms of polyuria, polyphagia and polydipsia. And on examination, she had thyromegaly with central adiposity and acanthosis nigricans. We proceeded on with the investigations. Her random blood sugar, which we did on her initial visit, was 432. Her lipid profile was deranged with a cholesterol of 224 and triglycerides of 153. So since we had a thyromegaly, we did a thyroid function test, which showed an elevated TSH of 266 and her T4 and free T4 were low. And we also proceeded on with the anti-thyroid peroxidase antibody, which was greatly elevated. It was around like 7,715.
She had a HbA1c of 12.5. Her other parameters like complete hemogram, renal function test, liver function test, and blood gas analysis, everything were within normal limits. So here we have a child who has features of type 2 diabetes mellitus along with an acquired hypothyroidism with autoimmune antibodies positive, and also a familial short stature, her mid-parental height being less with overweight. So our diagnosis where this is a preterm girl, SGA, born IDM with acquired hyperthyroidism, type 2 diabetes mellitus, overweight, and familial short stature. So the treatments, the first thing we stressed was lifestyle changes. So we told her about diet and exercise and also strictly on reduced screen time. We started her on thyroxine supplementation and also on metformin. And we taught her how to monitor her blood sugars, and she's monitoring her blood sugars strictly at home, like twice a day. Coming to type 2 diabetes mellitus in children, type 2 diabetes mellitus is because of the peripheral insulin resistance. So it is a polygenic disease. And in our case, she has a strong family history wherein like her maternal great-grandmother, maternal grandmother, and mom, all of them have diabetes mellitus. Plus, she was also born SGA, which is again a risk factor. Along with these, her sedentary lifestyle has also contributed to this presentation. So type 2 diabetes mellitus is aggravated by environmental factors, low physical activity, and excessive calorie intake, which has happened in our case. Most patients are obese, and they are unable to compensate for the insulin resistance by increasing the insulin production. They may be asymptomatic for a long time, and screening is also recommended for people who have risk factors from 10 years of age. So the mainstay of treatment will be lifestyle changes along with metformin in children above 10 years of age. Follow-up should be done meticulously with more concentration on retinopathy and microalbuminuria, because children with type 2 diabetes mellitus are more prone for these changes earlier than compared to type 1 diabetes mellitus children. So the take-home message will be like the tremendous lifestyle changes for our children will be the new tender love and care we can give for them. Thank you. And on behalf of all the presenters, we thank Ahila ma'am for giving us this opportunity and mentoring us.
Thank you, Divya.
Dr. Ahila, it's a very good, a clinical, combination. But then the expression used by her familial short stature, I don't think will apply to this child, because my understanding is familial short stature refers to healthy children who maintain normal velocity of growth, as pointed out by Professor Raghuvati. So that expression is really not applicable to this child. So that kind of, I don't think that expression you can use it for this particular child. Otherwise, the hypothyroidism and then this the combination, the autoimmune, thyroid involvement, short stature. But yeah, your comments on that. That expression I don't think is applicable to this child.
Actually, her growth was within normal centiles. Actually, it was beyond the mid-parental height centiles. MPH centile was just at the third or just below the third centile. She was actually at the 10th centile for her height. Though she had hypothyroidism, I think her obesity had her obesity-driven growth had put her beyond her mid-parental height centiles. So I think, as sir said, you cannot be familial short stature for this child. Divya, for your exams, that's an important.
Now, the other thing, since you have a combination of two autoimmune problems, should you look for other autoimmune disorders?
This is not an autoimmune diabetes, sir. This is
no, you autoimmune thyroiditis. You call it autoimmune thyroiditis, right? I'm sorry, autoimmune hypothyroidism. You call it autoimmune.
She has an acquired hypothyroidism, but her family, she's, as somebody mentioned in the discussion part, she had a birth weight which was quite low. She was born to a mother with gestational diabetes and born as an infant of diabetic mother. So she has more of early onset factors, unmodifiable risk factors from birth, which was not properly looked after. She could have made her lifestyle better and she could have prevented going into this. Because of poor lifestyle pattern, she stepped into type 2 diabetes, which is not an autoimmune problem. So she has only one autoimmune disease. So unless she develops another one, we just don't go chasing behind different autoimmune diseases.
No, please clarify, because she had a thyromegaly and also elevated antibodies in the serum. So don't you think that qualifies for an autoimmune process? She said elevated antibodies in the serum and a thyromegaly.
All children who develop acquired hypothyroidism, almost 80 to 90% of them are due to autoimmune process. Very few are post-operative or some other reason for hypothyroidism. So this is definitely autoimmune hypothyroidism in this girl. It was just incidental that she had both. She had Barker's hypothesis, which was playing a role. We don't go looking for other autoimmune disease unless they have two. Like type 1 and thyroid, I think Raghupati sir will agree any number of times in a girl, if you have hypothyroidism and type 1 together, we are very, very wary and we keep a sharp look out for SLE or any other connective tissue disorders or multiple autoimmune disorders.
So thank you for your clarification. Yeah.
20% of all diabetics develop thyroid disorder at some stage in their life. Similarly, thyroid patients, especially autoimmune thyroiditis, 20% of them develop type 1 diabetes. And that's something to remember. Why are
20%? I'm sorry, I didn't hear you well. 20% of them, the later part of the sentence?
20% of autoimmune thyroiditis may develop type 1 diabetes.
Okay.
This is another autoimmune condition. I was wondering why this is called Barker's hypothesis. Low birth weight, okay. Preterm, okay. At 1 year or 2 years, what was the weight? If the weight was more at 2 years, overweight at 2 years or more, or an adiposity rebound during 5 years of age, then they develop chronic non-communicable diseases at a later age, not during pediatrics. So we can't call this Barker's hypothesis.
One of the factors that we keep noting in children is waist circumference. When this girl's waist circumference was, we used the Kadalkar charts, which Vaman was talking about, published in 2014. So we marked them on the waist circumference, and this is quite huge. And those children with waist circumference born STA, I don't think we've seen too many of them, but we are seeing type 2 diabetes quite frequently, and because of these existing risk factors. And if you look at the acceleration in nephropathy in children with type 2 diabetes in early life, we thought that could be a possible contributing factor to the development of type 2 diabetes in this girl also.
You mentioned candida infection in the workshop. Actually, when a patient presents, especially a girl, when the girl presents with polyuria polydipsia, it's always good to look at the genitalia, and this is quite a common finding, candida infection of the vulva. Can it happen in boys?
We are seeing it in the glands also, sir.
Yeah, and I've seen one boy having almost like pyuria, and he was a 14-year-old boy, so I suspected something else, and fortunately he was innocent, and we proved him innocent. We tortured him enough to get that history.
Thank you very much. I think Dr. Thirumurugan Seran, I owe a deep round of thanks to him. He put up with my trouble to get all these information and then the credit hours and all that. And he told me I have to finish by 8:15. I finished by 8:04. I think he has to acknowledge that.
Thank you, ma'am. Thank you, ma'am.
Thank you.
I think it was on the dot.
Thank you very much, Dr. Ahila. Thank you, Dr. Simon, Dr. Annie. I think, thank you, Professor Raghupati. I think Professor Srinivasan was there. I think, one important point. Hello?
Yeah, there.
Yeah, no. Dr. Professor Srinivasan recently spoke on micronutrient deficiency. In that, he mentioned about dilated cardiomyopathy due to vitamin D deficiency. A very treatable condition. He was mentioning that. I think when the records was presented, the nutrition records were presented to us by the postgraduate I was reminded of that dilated cardiomyopathy due to vitamin D deficiency.
You already sent me a message, sir.
That's it has been reported in the literature, and we should miss it. You are right.
Actually, after that, I checked up, and there are more than 50 to 60 cases. And similarly, B1 deficiency, pulmonary hypertension. These are all treatable essentially. And the child, another child presented as myocarditis. You may remember. So I have already mentioned in the pediatric education forum in Coimbatore. Whenever you find unexplained myocarditis or pulmonary hypertension, kindly think of this and treat. There is nothing, no harm in giving a dose of B1 or vitamin D. Thank you, sir, for such a wonderful memory.
Thank you very much. Thank you.
You should call yourself very young, not octogenarian, which you said in the introduction.
No, 1000 பேரே முடிஞ்சது. But okay, I was here.
Thank you, sir. On behalf of IAPT NSC, I thank for your wonderful statement on endocrinology. I thank Dr. Agila Ayavu, and I thank today's moderator, Dr. Ramsamy MR sir, and Dr. Rashmi Velmurugan. Today's speaker, Dr. Vaman Kadirkar, Dr. Simon, and all other Dr. Akbari sir. Yes, really they presented very well, and it's a wonderful attendance also, and definitely that postgraduate has presented their cases very nicely, and definitely it will be a good interactive session. And I formally ask Dr. Tirumurugan to give a vote of thanks. Dr. Ismail sir. Yeah.
Thank you, sir.
Dr. Ismail sir, unmute sir, unmute. Dr. Ismail,
Yeah. Thank you, Dr. Agila, convener of this program, brilliantly executed, and it was so nicely designed to cater all those different areas for the clinical practitioners, and as well the students presenting different scenarios which a pediatrician commonly sees in his clinic. And thank you all the faculty members and the chairpersons and all the delegates who had attended today. Thank you.
Yeah, thank you, sir. I think we have been doing, this must be I think the 9th CME we have been doing. IAPT NSC has done since the start, kind of from September last year. And I think for the first time we have hit the brief up to the point. See, I think we got our the design of the program right, because we had some very good speakers. I was amazed to see the number of people who are involved in this CME. I mean, pediatric endocrinology, it's very unlikely to have such a crowd. So I think thanks to Dr. Agila Ayavu as a convener who has organized such a wonderful program. I would thank all the speakers before and the moderators. I mean, both Dr. Lakshmi Velmurugan and Dr. MR sir for being such wonderful moderators, and all the wonderful speakers, very good speakers who have done a fantastic job of enlightening us. I mean, for once, this was a CME which is just not boring at all. I mean, I think that's, we usually have at least 1 or 2 topics which are a bit dodgy, but I think today we had every topic which was fantastic. So once again, thanks to Dr. Agila Ayavu. And also the postgraduate presentation was something new. Maybe we should think about those in the next set of CMEs as well. So I would like to offer my thanks to all the speakers and the presenters. My special thanks to our president and our secretary. I think they have been very much instrumental in organizing these programs. And then I can proudly say, I think IAPT NSC is the most active branch among all the branches in the country. So thank you very much for all the delegates who have attended this program. Just a point to remember, for the TNMC credit points, we request you to reach out to the IAPT NSC website and then fill in the form there, and also make a payment of 250 for as the registration fee, and that should be done within Thursday, so that we'll be able to apply to the TNMC website. So thank you very much, and hope to see you next month. Thank you.
Thank you. Thank you.
Thank you, sir.
Thank you, sir.
Emma sir, Raghupati sir, I have tortured you as usual. I told
thank you, Raghupati sir, and thank you, Emma sir.
Anna, thank you so much, Anna.
Thank you, ma'am. Thank you, ma'am. Actually, unmiyave nalla irundhuchu. கரெக்டான ப்ரோக்ராம புடிச்சிட்டீங்க.
நேத்திக்கு தான் சொன்னீங்க அந்த ஹாப்பினஸ்க்கு கம்பேர் பண்ணாதீங்கன்னு. திருமுருகன், நீ வந்து டோன்ட் கம்பேர் வித் அதர் ஸ்டேட்ஸ். யூ டோன்ட் நோ வாட் இஸ் ஹேப்பனிங் அதர் ஸ்டேட்ஸ். I know
அப்படி இல்ல சார், நாம நல்லா பண்ணணும்னு சொல்றது ஒரு சந்தோஷம் தான் சார்.
That you can say, but never try to take, without statistical analysis such a statement. Okay, because I have been attending many of these this thing programs.
நீங்க எல்லாத்தையும் சேர்த்து பாக்குறதால உங்களுக்கு நிறைய அவங்க பண்றவே தெரியுது சார்.
ஸ்ரீனிவாசன் சார், நேத்து அந்த 5 ஆஞ்சியோபிளாஸ்டி கதையை சொல்றீங்களா?
இல்ல, கம்பேர் பண்ணாதீங்கன்னு. நேத்து தானே சொன்னீங்க அந்த ஹாப்பினஸ்.
We can mention ourselves, not comparison. I think I agree with Professor Srinivas.
You have to be very careful. Thank you. Report in சொல்லக்கூடாது unless you have screened the whole literature to find out. There may be earlier one case presented like that.